Good morning. Now, Ms. Graham, the first witness today is Dr. Gillian Pickering, is that right?
Correct, yes.
Good morning, Dr. Pickering. You're going to be asked questions by Ms. Thompson, whom you've already met. Before that, would you take the oath and raise your hand, please? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Ms. Thompson.
What is your full name, please?
Gillian Moffat Pickering.
Do I understand correctly that you're a consultant in emergency medicine?
Yes.
How long have you been a consultant?
Almost 4 years.
What are your professional qualifications?
MB, CHB, MChem and FRChem.
So the MBCHB, that's the medical
Medical
degree,
degree, yes.
is that correct? And the second of your qualifications
BM
was?
First stage is member of the College of Emergency Medicine and then a fellow of the Royal College of Emergency Medicine.
Doctor, can you open up the folder that's in front of you, please? I want to make sure that you have everything that you might need in giving your evidence this morning. There are a number of documents in there. The first should be a statement that you gave to the inquiry, reference 00028. Do you see that?
Yes. Yeah.
Do we see that this was a statement that you provided to a member of the inquiry team in 2 sessions on the 10th of December and on the 23rd of February of this year?
Yes.
Can we turn to page 24, please, paragraph 124?
Yes.
Do we see that you have concluded the statement with the words, "I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry and be published on the inquiry's website."
Yes.
And you have signed the statement, every page of the statement, and the date of your signature is the 11th of April of this year.
Yes.
Is that correct? So although your signature has been redacted out, you'll see on the document on the screen, there should be a signature on the hard copy in front of you. Now, the statement that you provided to the inquiry team is already evidence before the inquiry. I don't intend to go through it line by line, but if I want to ask you questions about any particular paragraphs, I'll ask that they be put up on the screen in front of us. Returning to the folder, we don't need to put these on the screen, but you should have 2 statements provided to the Police Independent Review Commissioner, or the PIRC. The first is dated the 14th of May of 2015.
Yes.
And the second, the 15th of June of 2015. And both statements were given to a DSI Miles.
Yes.
Are they both there in your folder?
Yes.
If we can return to your inquiry statement, same page that we were on a moment ago. That was page 24, at paragraph 123. Do we see that you have said, "I remember giving 2 statements to PIRC. I told PIRC the truth, and my memory would be better then than it is now. I read over my statements and signed them. If there is an inconsistency, my previous statements should be preferred, aside from the point about whether the handcuffs hindered CPR."
Yes.
So we'll return to the handcuffs issue, but leaving that to one side for now, should we understand that if there are any differences between your inquiry statement and your PIRC statement, the chair should prefer your PIRC statements because they were closer in time to the incident and your memory was better then than it perhaps is now?
Yes.
Returning to the folder, you should also have a set of A&D records with reference PIRC 01069. We don't need those on the screen just now, thank you.
Yes.
Are they there too?
Yeah.
Okay, so you can dip into all the documents in the folder if you would find it helpful to do so as you give your evidence. If I can take you back to 2015, Doctor, I understand that you were a registrar in the A&E department of the Victoria Hospital in Kirkcaldy.
Yes.
You were what was known as a specialty training year 5.
Yes.
What does that mean?
Senior registrar, our training is 6 years. I did a bit extra for paediatrics, so it kind of goes from ST1 to ST6. Some people will do a bit extra. So ST5 is at the near end of finishing.
So would that be 5 years after you graduated from university?
No. So I've done my FY1 and FY2 in 2008 and 2009 and 10, and then go into A&E training in 2010.
So did you graduate in 2008?
Yes.
2009 and 2010 you did FY1 and 2. Is that foundation year?
years, yeah.
Is that a general practice or is that
It's
specialty?
6 specialties of lasting 4 months each.
Was one of those specialties for you A&E?
No.
No, it wasn't. All right. And you then commenced your specialty training, which you've explained lasted
Yes.
6 years.
So mine lasted a bit longer because I did paediatrics as a subspecialty, and I did extended a bit of training as well. So I started that in 2010 and finished in 2018.
Was all of your specialty training, albeit there was some degree of focus on paediatrics, was all of your training in emergency medicine?
From ST4 onwards, the first 3 years is a mixture of A&E, paediatrics, acute medicine, intensive care, and anaesthetics.
So by the time you were working as an ST5 registrar in 2015, how much experience did you have of emergency medicine?
By that point, we'd be at least 2 to 2.5 years of pure emergency medicine, along with other specialties.
And how many years of, if I might call it, postgraduate practical medical experience did you have by that point in time?
That would be 7 years.
In a number of specialties, including A&E. Doctor, you were on duty at the Victoria Hospital on the morning of the 3rd of May of 2015, when a man who we now know was Shekubayo was brought into the A&E department by ambulance. And I want to ask you questions about that this morning. Do I understand correctly that he arrived at the hospital shortly before the shift change, which was at 8 o'clock in the morning?
Yes, I think it was the box. I think it probably was just after about 7:30 in the morning.
You mentioned the box?
So the box would go off to tell us if there's a crash call coming in, if the ambulance want us to bring a patient straight into resus.
Okay, explain what that means. What is this box and who can communicate through the box?
Yeah, so the ambulance crew will phone in patients who need to be seen immediately. And that can vary from patients who have respiratory distress, who are in extreme pain, traumas, cardiac arrest, etc. They will put the call through to a box that gets answered very quickly by one of the nursing or the medical team, and then we will have a team ready to receive the patient as they come in.
And is the purpose of this to allow the team to be assembled
Yes.
and at the ready when the patient is received? What information did you have before the patient arrived at the hospital?
From what I can remember, we had a male coming in who had collapsed. I don't recall if he was in respiratory or cardiac arrest from the crash call. I just remember a story of him being collapsed and was coming in to us, and that we needed to be ready for him coming in. And it was only a standby time of maybe about 5 minutes, if less than that.
We've heard that he had become unconscious on Hayfield Road. That's very close to the Victoria Hospital. Is that right?
Yes, I don't know Kirkcaldy very well, but yes, from what I understand
sorry.
it was.
So what preparations could be made or were made between you receiving this crash call and the patient's arrival at hospital?
So depending on what is put through on the box, we will go and check that the anaesthetic machine is working, that we've got the oxygen. We have a thing called a C-circuit or a valve mask, so we have that ready in case we need to do any airway work. We'll make sure we've got ready to put a line in and take bloods and give drugs, and we will have sufficient number of teams, so there'll be a senior doctor, which was myself, another doctor, and at least one nurse, possibly 2 if we can, if we're spare.
Were these the sorts of preparations that were put in hand on this occasion? Can we pull up your inquiry statement, please, and go to paragraphs 19 and 20? You say the patient then came in. He was on a trolley from the ambulance. He had been seen by the ambulance crew and they brought him to resus. He came out the ambulance doors, into resus and straight to me. He doesn't go anywhere else. Resus is a big bed area and I think it had 8 beds. If you're looking down resus, he was put in the first right cubicle. I positioned myself at the head end because I'm the senior on at night, so I was at the head end. I was the decision maker in A&E at this time. I then allocated the juniors to their roles. So just to be clear, should we understand that, at least at the outset, you were in charge of this patient and in charge of his resuscitation?
Yes.
I want to ask about the personnel involved. You mentioned that typically there would be 2 doctors and a nurse, perhaps more. On this occasion, in terms of the A&E staff, you were in charge. Were
Yes.
there any other junior accident and emergency doctors assisting you?
Yes, there was a junior, Dr Sophie Rowlings, who I did my night shifts with. We were paired together on the rota, so she would have been in the resus room with me. There was a nurse. I couldn't tell you the name of who that was. There may have been 2 nurses. I don't know if there was another junior with me. I just remember Sophie definitely being there, though.
Okay. So at least 1 junior doctor,
Yeah.
at least 1 nurse.
Yes.
And it may have been later on in the course of the resuscitation, but am I right to understand that a consultant anaesthetist became
Yes.
involved at one stage?
I recognised that this was a young male, and in these situations you do want to have more help if you can, and therefore I did fairly early on ask for someone to phone the anaesthetic consultant. I think I'd already met him earlier in the night with another patient, so I knew he was in the hospital, so I did ask that he got called to come down and join the team.
And was there also an ITU consultant involved at
I
some
think
stage?
there was at some stage. I don't remember when they appeared.
So that would be at least 4 doctors, possibly more, 2 at consultant grade, plus yourself leading on the resus, and at least 1 nurse were
Yes.
involved in the resuscitation effort. Doctor, when Mr. Bio was brought to you on a trolley, can you describe what you saw in front of you?
Yes. So the patient will come in on the ambulance trolley. I would be standing at the head end. He would move from their trolley onto our trolley. He was I remember him being a very big man. I remember him coming across. He had his handcuffs, his hands in front of him on his chest, cuffed. And I remember there being a mark on his forehead. And then it comes over onto our trolley, and then we start doing what we have to do.
I want to ask you some questions about the information that was provided to you at about the point of this handover from the paramedics to yourself. It might help if we were to call up the A&E notes. And if we look at page 4, do we see under patient data, surname unknown, forename unknown? So at the point that Mr. Bio was brought into you, you didn't have a name, you didn't know.
No, we didn't know who he was.
Scrolling down a little, please, do we see that he was admitted or seen at 7:50 in the morning?
Yes, that will have been written by myself after the event, because obviously I can't do it at the time.
Of course.
So I know it was between 7:30 and 8 o'clock, but I couldn't tell you exact time other than what's written there.
I see. So these notes were made retrospectively by you.
It happens, pretty much straight after the event. So 7:50 is probably as accurate as it will be.
I think you explain, in fact, in your statement to the inquiry that you wrote up the notes at about 9 o'clock in the morning. We see your name there, Dr. Pickering.
Yes.
And is that your handwriting?
Yep.
If we could turn to page 7, please. Again, is that your handwriting?
Yes.
And very briefly, we'll return to page 7, but page 10 as well, please. Is that also your handwriting?
Yes.
Returning to page 7, we see that you've recorded at the top, written in retrospect, and 0900 hours. That would fit with what you told the inquiry team that you wrote the notes up at that time. You mention your name and Dr. Rowling's. PC, what does that stand for?
Presenting complaint.
Can you read out, please, that paragraph?
Found by police with knife, aggressive, attacked police officer, pepper gas used and uncooperative, hit on back of head, then was in respiratory arrest, with ambulance crew, cardiac output, no respiratory effort.
Who provided that information to you?
It would be the police officer.
The police?
Yes.
Rather than the paramedics?
No, I'm sorry. It would be the paramedics would have told me that story, and then if I wanted to confirm it, the police were there if I wanted to ask, but I don't recall asking.
So to the best of your memory then, the information came from
The paramedics. Yeah, sorry.
What's the purpose of noting a history? What's its relevance from your perspective?
It gives us an idea of what potentially may have caused him to go into respiratory arrest and then cardiac arrest. It lets us know what led up to the events. If we just had a patient come in with no history, you then have to do a bit of digging to figure out what happened, so it's useful to have the story from the paramedics of what occurred beforehand.
Can we return to your inquiry statement, please? Paragraph 27 onwards. Now, I'd like to go through a number of paragraphs here, Doctor, just so that we can be absolutely clear as to the patient's condition at the point at which he was received at A&E by you, and in particular, whether he was in respiratory arrest or in cardiac arrest. I think it might be the case that you had advised the PERC that he was in respiratory arrest. By the time you gave a statement to the inquiry some 7 years later, your recollection was slightly different.
Yeah, on reflect, when he first came in, from what my first statement says with the police, was that he was in respiratory arrest and then he went into cardiac arrest. I think my statement to the inquiry was that he was in cardiac arrest because I couldn't remember if he had been in respiratory arrest first. Basically, within about 2 minutes of him coming into the department and being in respiratory arrest, he went into cardiac arrest. So it was very short time that he changed. Yeah.
If you'll bear with me, I'd like to read this page in its entirety because this could be an important issue.
Okay.
So let's go through it. You check for pulse when they come in, and then you check it again every 2 minutes as part of the algorithm. When he came in, his pulse may have been checked by Sophie or one of the nurses. While the paramedics gave the story, I was feeling for a pulse. There was no pulse, so I told the others he's actually in cardiac arrest and to start CPR. He could have been in respiratory arrest with the crew, and that's why they were bagging, but he definitely had no pulse when he came into the resus room. I've been shown my previous statement at page 2 where I said I had checked his carotid neck artery and had found a pulse. I genuinely don't recall that. I do vividly remember us doing CPR very quickly. I suspect I felt it, looked to get the story, and then felt it again and noticed it had gone. If I had felt the pulse, then I would have gone on to do other things, and we obviously haven't done those. I've been shown my previous statement to PERC dated the 14th of May, and on page 2 in the first paragraph I state, the message related to a young male cardiac arrest. Further down page 2 in the first paragraph I state, at this time when radioed in, he was in respiratory arrest, but had come over the radio as a cardiac arrest, which was wrong, as he had a pulse when he came. The radio is the same as the crash box. What I said previously must be true. He didn't have the pulse for long, that much I can tell you. My memory is that he was in cardiac arrest, and he was in cardiac arrest very quickly. It was less than a couple of minutes, and then he was in cardiac arrest. I can't remember who took the call. I see in the A&E records at page 7 I've written, in resus initially, ventilated by a C-circuit, pulse lost within 2 minutes. I just don't remember him having a pulse initially, but that will be true and accurate. So should we understand that although the passage of time may have affected your recollection, the statement that you gave to the PERC was true and accurate, and that statement was given relatively shortly after Mr. Bio passed away, and that in fact when you received him, he was in respiratory arrest as opposed to cardiac arrest, but within a couple of minutes he'd gone into cardiac arrest. Would that be a fair summary?
Yes.
All right. I'm going to move on shortly to ask you questions about your assessment and treatment of the patient. But before I do that, I think it might be helpful, because we've spoken about respiratory arrest and cardiac arrest, if I might ask you to explain some of the terminology. So what is respiratory arrest?
So respiratory arrest is when the patient isn't breathing for themselves. Their heart is still working, it's still pumping, but they're not making any breathing effort, and you have to do that for them. that can lead on to cardiac arrest, and then that's when the heart is not working, and then you have to start CPR.
How would you treat a respiratory arrest?
So you would take over, you'd go up to the head end and you would start giving ventilations, depending on the equipment you've got. In Fife, from what I can recall, it was a bag valve. It was a bag valve. The ambu bag that you used, and you would give ventilations to help the patient to breathe. You would then get the story of what had happened to decide what you could figure out why this had happened and what you needed to do next. If needed, you would potentially give him some drugs to paralyse and to put a tube in and take over their breathing and put them onto a ventilator if that was appropriate. It may also be that you could give some drugs to reverse any effects of anything they may have taken to start them to breathe again themselves.
All right, so when a patient is in respiratory arrest, they're not breathing for themselves, you need to breathe for them.
Yep.
And that could be by use of what you've called an ambu bag?
Ambu bag, yeah, so it's there's two different ones that people can use. There's a C-circuit machine that attaches to the anaesthetic machine, or you've got an ambu bag which just goes to an oxygen supply, and you can use that, and everybody would know how to use an ambu bag.
So as the name describes, is this some sort of bag that goes over the patient's
so it's
mouth?
a mask that goes over the face, and then it's got a reservoir plastic bag that you squeeze to give oxygen, and then it's got another plastic bit on the end of that, and then a cord that it can attach to oxygen.
Okay, so this is a way of forcing oxygen
Yes.
through the mouth into the lungs.
Yes.
Or the other artificial ventilation technique that you described would involve a tube, is that right?
So you could intubate as well, yes.
Intubate and ventilate.
Yes.
And we perhaps don't need to go into the technical details, but would that involve the patient being on a machine that was
Yes.
doing the breathing for
So
them?
you can put a tube in through and take over their breathing by attaching the ambu bag to the tube and still do the manual bagging yourself, or you attach them to a ventilator where the machine will do it for you.
So that's how you would treat a respiratory arrest. You said that when the patient, or if the patient goes into cardiac arrest, then the treatment is CPR.
Mm-hmm.
And I'm going to go on to ask you some questions about CPR shortly. But can you help me to understand, firstly, how it is that a respiratory arrest can lead to a cardiac arrest? How does one lead to the other?
It's more to do with the lack of oxygen, supplying parts of your brain that then control the working of the heart. It's kind of to do with the medullary receptors, and the regulating of the heart is quite hard to explain in a sentence. But basically, if you're not oxygenating your brain, you're not being able to supply the right bits that then will send the messages to tell your heart how to work. So then you will go into cardiac arrest.
So one can lead to
Yes.
the other.
Well, respiratory arrest will lead to cardiac arrest if you don't deal with respiratory arrest.
So that is inevitable. If the
Yes, it
respiratory
will. If you're not breathing for yourself for a length of time, you will go into cardiac arrest.
So if that is not that situation, the respiratory arrest is not reversed, then cardiac arrest
Will
will
happen.
inevitably follow.
Yes.
What then does CPR involve? Firstly, what does it stand for?
Cardiopulmonary resuscitation. So for an adult, that involves 30 compressions on the chest to 2 breaths, doing that for a cycle of 5 times or 2 minutes, and then rechecking for a pulse. And then depending on whether you have a pulse or what rhythm is on our defibrillator, because we'll attach them to pads and see what rhythm they're in, and depending on what rhythm they're in, we will then decide if we need to give electric shock or not.
I'll ask you more questions about CPR later, because I understand that that was the treatment or the management that was used for this patient. But we'll leave that to one side for now. Mr. Bayo was wearing handcuffs
Yes.
when he was brought into A&E, and in fact, when you gave your evidence, you put your hands in front of you to
Yes.
demonstrate the position of the
Yes.
cuffs.
They were in front of him. I can't remember if they were crossed over or together like that.
In any event, they were to the
Yeah.
front rather than
Yes.
to the back, and you asked for them to be removed.
So no, what happened was when I said he's in cardiac arrest, the police officer that was standing at the end of the bed said, "Do you want me to take the cuffs off?" And I said yes.
I beg your pardon.
No, it's okay.
If he hadn't made that offer, would
Yeah.
you have asked for
Yes.
him to be removed? Can we go to your inquiry statement, please, at paragraph 49? Again, I'd like to read this out and then ask you some questions. Handcuffs would hinder CPR because if somebody small like me was standing over him on a stool doing CPR and his arm is in the way, then my hand might not get full contact with the chest. You're doing compressions on the centre of the chest, over the middle and over the sternum. If the hands are over the body and they're a big person who's got big hands, you might not get your full hand in over the area you need to compress. Whereas if you've got things away from the chest, you've got full exposure and you're able to get proper, decent compressions. It doesn't stop you doing CPR completely, but it can hinder it. So you give an explanation there as to how cuffs might hinder the CPR effort. If we can scroll down to paragraphs 50 and 51, please. I've been shown my previous statement to Perk on the 15th of June. On page 2 I said, the male was lying on his back and was handcuffed. He did have a large chest and his arms were positioned lower on his stomach. This would not have impeded in any way attempts to perform CPR, as this requires work on the sternum. I think what I was saying in the statement was that they wouldn't have impeded CPR because they were off straight away. Had they stayed on, then they would have been in the way. The CPR would not have been as good. If his hands were down towards his stomach, then his upper arms would have been across his chest a bit and impeded CPR. If we could very quickly fast forward to paragraph 123, this, Doctor, you'll recall, is the paragraph in which you said that that you told the Perk the truth and your memory was better then than now. If there's an inconsistency, your previous statements should be preferred, aside from the point about whether the handcuffs hindered the CPR.
Yeah.
And you've given a clear explanation in your inquiry statement as to what had been said to the Perk and what you in fact meant by what you said to the Perk. And you're very clear in your inquiry statement that CPR would have been hindered by the cuffs.
Yes.
And you also have given evidence that if the police hadn't offered to take them off, you would have asked for them to be removed.
Yes.
Can we return to paragraph 52? It would be very difficult to get IV access in the arms if the arms were cuffed. It's very difficult to get into that area. We usually go for the anterior cubital fossa on the inside of your arm where the elbow bends. We usually go there in resus because the back of the hand is usually very shut down. If the person's in cardiac arrest, they're going down in their extremities first, so the veins are not going to be easy to see. You want access quickly so you can start giving drugs. So you explained there another reason why cuffs might get in the way, and it's to do with access to veins.
Yes.
Doctor, we've heard that CPR was performed at the scene on Hayfield Road by officers and paramedics, and this continued in the ambulance on the way to hospital. Can you comment on whether, if the cuffs had been removed while CPR was being carried out at the scene by the police and the paramedics, would have made any difference to the outcome here?
It could have. The gentleman was a big guy, and his arms were big, and they were across his chest. To do good effective CPR, you need to be able to get good access to the chest to do good compressions. The police are trained in doing CPR and will be delivering as good compressions as they can, opposed to someone who is not experienced in it. So that I can only assume that they were giving as effective CPR as they could. Whether the cuffs in the way, it would have hindered giving really good compressions.
Can we look again at paragraph 49? halfway through, you say if the hands are over the body and they're a big person who's got big hands, you might not get your full hand in over the area you need to compress.
From what I remember, he had a big chest and his hands were right across and over his front of his body. So that space there where I need to put my hand to compress would be small. And if the hands are cuffed, you might not be able to get your hand in there very well.
So when you're talking about hands in that sentence, are you talking about the hands of the patient or the person who's giving the CPR?
So the person who's got big hands is the patient who, if they've got big hands and big arms, I suppose arms is more what I mean, is in the way. And if the person who's giving CPR has a big hand, they're going to struggle to get their hand into that space as well.
I see. So if the person giving CPR has large hands, then that might also hinder
getting in. Yeah.
effective compressions in circumstances where the patient is cuffed.
Yes.
I'd like to ask you some questions now about your assessment of Mr. Bio in accident and emergency. If I can take you to paragraph 35. You say, as soon as a patient is handed over to me, I will start to reassess the patient from the beginning. We have a system, A, B, C, D, E. It's a very easy system for A&E doctors. Each letter is as follows: airway, breathing, circulation, disability, environment. We work our way through that from A to E. I'd like to ask you some questions about that. So A is for airway. What was your assessment of Mr. Bio's airway?
So he wasn't breathing for himself, therefore we needed to deal with that first before you can move on to breathing. So at that point, I don't know if you want me to keep saying what I did next or just explain airway.
Carry on,
Okay.
please. Thank you.
So from an airway point of view, we then would have a look to see if we can put a tube in to his trachea and take over his breathing. I remember having a look and not seeing that I could get a tube in, so I put an LMA in, I think, instead, which is a slightly different type of tube that doesn't go into the trachea, but it sits at the back and the top of the epiglottis. And at that point, I think probably is when I asked for anaesthetics to be phoned. Then was bagging. At that point, I'm stuck at that end. I can't leave airway when I'm at the airway doing the bagging. So I would have got probably Sophie Rowlings to look at B, which is breathing. So checking if there was any trauma to the chest, if there was any breathing effort at all, have a listen. Then would look at C, which is circulation, to see if there is what the pulse is, what the blood pressure is, whether he's shut down peripherally. So what I mean by that is if they're cold in their hands or if they're warm in the centre. Then move on to D, which is looking to see if there's any marks anywhere, what their conscious level is, what their pupils are doing, and then E is looking for exposure to check if there's any injury on the back. We did not get down to E very quickly because we got A, he wasn't breathing, and then he lost his pulse, and then therefore we change what we are doing to a different algorithm at that point, because this is assessing a patient that's awake or a patient that's alive. Whereas if they have no pulse, you have a dead patient and you have to start a different system.
All right, you gave me a lot of information there, so no, not at all. That's incredibly helpful, but what I'm going to do is just take you through some of that in a little more detail, and then we'll move to the alternative algorithm, which I think is for CPR.
Yes.
Is that right? Yes. So this A, B, C, D, E is applied indiscriminately to any patient who comes in. This is your working model, but where the patient doesn't have a pulse, it's only going to take you so far, and then you have to move on to a different algorithm. Is that correct?
Yes.
So far as this patient was concerned, airway, he wasn't breathing. You've described putting a sort of half tube or a gadget into his throat to give access to the airway. Is that right?
It's a breathing it's called a laryngeal mask airway. It's an airway adjunct is what we would call it, and it allows you to give oxygen and prevent too much secretions and vomit getting into the airway if that was the case, but it allows you to better than nothing basically. So it's a good extra device until you can get a tube through the trachea, because that's ideally what you want, because you want what we call a cuff tube through the trachea, because that's a protected airway at that point.
So that hadn't proved possible, is that correct?
Yeah, I couldn't see, so I couldn't get,
All All right. So this was the next best thing,
Yes.
pending the arrival of the anaesthetist, who was
yes.
going to assist you with
And
supporting the airway.
Yeah.
Okay.
Yeah.
So that's the A.
Yes.
The B was the breathing, and you said that Sophie Rowlings was helping you in that
I
regard.
can only assume that that's what Sophie was doing because I can't move from Airway. That's where I am. Although I'm the senior doctor, and during the day, if you're the senior doctor, you will probably be standing at the end of the bed, overseeing and directing everybody. But at night, there's less people around, so you have to take the roles as well. So I was at the head end. I wouldn't have been able to move from there, and until anaesthetics came down, and then they would take over, and then I moved to the foot of the bed. So Sophie, I would assume, was doing B because I wouldn't have been me.
What would she have been doing? Because you've already said this patient wasn't breathing.
Wasn't
So what
breathing.
was she looking at?
So when I'm bagging, I will inflate the lungs. So she'll have a listen to see if she can hear anything, if there's any collapse of the lung, if there's any decreased air entry that would give us an idea of whether the lung had collapsed, or whether there was secretions or any extra noises that would just give us a bit more information of what could have led to the event.
So you were using the ambibag that you've
Yes.
described
Yeah.
earlier, and this is to force oxygen into the lungs?
Yes.
Via this
the
adjunct that you
Yep.
have described. And Dr. Rowlings, in the meantime, would have been effectively monitoring whether that was effective.
Yes. Yeah.
C, circulation, you said you would have checked blood pressure, pulse, peripheries, and there was no pulse.
There's no pulse.
So at that point, should we understand Mr. Bayo effectively dropped off this algorithm, it was no longer valid, and you had to move to the CPR algorithm because...
Yes, if they have no pulse and they're not breathing, then we have to move to what we call advanced life support, which is starting CPR and following an algorithm with that.
So if a person isn't breathing and has no pulse, does that effectively mean they're in both respiratory and cardiac
Yes.
arrest? Before we discuss the treatment that was given in terms of the CPR algorithm, I want to ask you some questions about your sort of differential diagnosis, if that's the correct term, in terms of the potential causes of the arrest. And if we can perhaps turn to page 60, paragraph 60 of your statement. You say, for the assessment of cardiac arrest, there's a list of things that you would think about when someone comes in. He came in unconscious with not really any hint of what has caused him to arrest. I had a list of things in my head to think about. And if I can pause there, you said earlier in your evidence that when you get a history from the paramedics, it's to give you an idea of the potential causes or the range of potential causes. And the history that you received on this occasion was fairly limited. Would that be fair?
It was more of what had happened before he just came in with the police and the paramedics. I didn't have an idea of what happened leading up to the encounter with the police and the paramedics before he came to us. So, as much as it told me that he'd had pepper spray and had been put to the ground, it doesn't necessarily tell me a lot about what has led up to that event in the first place.
Paragraph 61, you say, the first thought is trauma, because I could see there was a mark on his head. My thought was, to explain this as simply as I can, whether he had enough trauma on his brain causing pressure on his breathing and heart control centres, causing cardiac arrest. I checked for trauma. The patient's head was the only site that I could see any injury. There was no other obvious trauma that we could see externally. This means checking for swelling or broken bones that could cause a loss of blood volume. There was no deformity that may have caused this. So, should we understand that you'd effectively excluded trauma as a potential cause of cardiac arrest?
So there's a few things for young people that would cause cardiac arrest, and trauma is the most likely, or one of the most likely. So he had a small mark on, I think, above his left eyebrow, on his head, but we'd have a quick look to check there wasn't anything else around his head. And what I mean by that is looking for any bits that would indicate a cracked skull. So we'd feel for what we call boggy hematoma. So that's a bit like feeling wet moss, is the easiest way to describe it. So trying to feel for that on the skull, checking if there's any blood coming from his ears, any bruising or blood behind his ears, just looking for anything that would give me an indication of whether he'd had a head trauma, being the most likely thing to potentially have caused him to go into cardiac arrest. And because of, if he'd had a head trauma with a big bleed, it would have caused pressure, etc. The other things to think about from a trauma point of view, was there any evidence on his abdomen? Had he bled out? Is his spleen ruptured and he's bled out into his abdomen, causing him to go into cardiac arrest from what we call hypovolemia? Then the second thing, other thoughts would be, was there anything, his femur, had he broken his leg? Something like, these are the things I'm looking for to check where's the blood loss that would cause him to bleed out and to go into cardiac arrest.
So the only apparent injury was to the head.
Yes.
Can you describe the injury that you could see on his head?
From what I can remember, it was a small abrasion, like a graze on above his eyebrow, not necessarily significant enough to have caused a traumatic brain injury.
But in addition to seeing that abrasion you've described, going on to examine the head for boggy places, checking for bleeding in the ears and so on.
Yeah.
Was this all to ascertain whether there might have been some underlying serious head injury that might have accounted for the arrest?
I mean, at the point where we knew his pulse, that he didn't have a pulse, we would be starting CPR and working through what we call the 4 H's and the 4 T's, which I'm sure you'll get to.
We'll come on to those, yes.
So once I've gone through those to check there's not a reversible cause for the arrest, because that's what I want to get fixed first, I'm then thinking in my head, what has caused, what else can I think of that isn't in those 4 H's and 4 T's that I need to be thinking about? So head trauma, bleeding out, things like that would be also in my head as I'm going through it.
I see. So did you go through your 4 H's and 4 T's?
I would go through my 4
first?
H's and 4 T's first, because they are reversible causes of cardiac arrest, and if I can fix those, I can get his heart to restart, and then I can worry about the other things that might have led up to it. But I am thinking about them at the same time. I just know I have to go through these things first.
Well, why don't we go to the 4 H's and 4 T's now, and then we'll perhaps come
Yep.
back to the head injury and the other possibilities that were in your differential diagnosis after you'd excluded, as
Yes.
I think you did,
Yeah.
the 4 H's and the 4 T's. Can we go to paragraph 89 of your statement, please? And as you have just said in your evidence, Doctor, you have what are called in emergency medicine reversible causes in cardiac arrest, 4 H's and 4 T's. If you can identify one or more, you can possibly reverse the cause of the cardiac arrest and stabilise the patient. So moving on to paragraph 90, the 4 T's begin with tamponade, where there's blood in the pericardial sac, so the sac around the heart. So if there's been trauma to the heart, you can get blood compressing, stopping the heart from being able to beat. Was there any indication that that was the cause here?
No. The reason for not thinking it was that or not is because tamponade wouldn't happen quickly. It would be a leak into the sac around the heart, and he would slowly be getting worse, and you would see signs of his heart rate going up and his blood pressure dropping, and ideally, clinically, you should see the veins in his neck getting bigger as well. So it's not something that you would suddenly collapse and pass out with. It's something you would realise that was where it was going. You'd also have evidence of trauma to the chest, so if they'd been stabbed in the chest is the most likely thing for cardiac tamponade, or a road traffic collision with full impact. These sort of things tend to be what causes a tamponade.
So should I understand that there wasn't any history or clinical presentation?
The clinical
that was
history,
there?
from what I knew and from what I could see in front of me, didn't fit with cardiac tamponade.
Returning to paragraph 90, the next T is toxins. That can be intentional drug overdoses, accidental drug overdoses, recreational drugs, medication, anything like that. This can be illegal or prescription drugs.
Mm-hmm.
Was there any indication that that was relevant here?
I hadn't been told by the crew that there had been any history of drug use that I can recall, but in my head I was thinking this could be drugs.
Why were you thinking that?
The causes for a young male or female tend to be sometimes misadventure. For cardiac arrest in young people to die is trauma, misadventure, or underlying illness. The most common causes tend to be misadventure from drug use, intentionally or recreationally. Our trauma tend to be the main causes. From a little bit of what I've been told about potentially having been aggressive on scene and then suddenly collapsing with respiratory, then going into cardiac arrest, does make me think, has he taken anything on board? So drugs were in my head as a potential cause.
There's a little bit more about drugs as a potential cause in your statement, so I'm sorry for jumping around a bit, but can we perhaps go to paragraph 63? This follows on from the paragraph where you discuss potential trauma and looking for signs of injury. I then thought he may have taken drugs and ended up putting himself into an arrhythmia. Drugs can cause you to have seizures and potentially go into cardiac arrest if you're hypoxic for too long. Hypoxic means not getting enough oxygen. Before we go any further, what's an arrhythmia?
So it's an irregular heartbeat. So you've got normal sinus rhythm, which is what we all are in, but you can go into other rhythms, and sometimes certain drugs can put you into what we call ventricular tachycardia or ventricular fibrillation.
Paragraph 64, if you have a seizure for too long a period of time, you cannot get enough oxygen to your brain. You have respiratory arrest and then a cardiac arrest. Drugs can cause your heart to go into different rhythms. It can then cause you to arrest as well. I wondered if he might have taken an opioid overdose, heroin or a variation of heroin, and therefore I gave him a drug called Naloxone to try and reverse that. That didn't really do anything. I don't remember how many times I gave that. So you were considering, given his age and given your own knowledge and experience, that misadventure is a cause of arrest in young people.
Yes.
You were considering the possibility of an opioid overdose, accidental or otherwise, and gave him naloxone. Is naloxone, to use lay terminology, an antidote to...
Yeah, it competes with the opioid on the receptors that the opioid would bind to in the body, and therefore tries to reverse the effect that the opioid drug would have. So it's Narcan is probably the name that most people would know it as.
Now, you've described in the paragraphs that we've looked at drugs, in particular opiates, causing cardiac arrest. Can drugs cause respiratory arrest?
So opioids can. They can depress the respiratory centres in your brain and therefore cause you to go into respiratory arrest.
Can other drugs aside from opioids have that effect? To your knowledge?
Yeah, they can. I can't think of lots of them off the top of my head, but there's we kind of classify drugs, or in particular recreational drugs, into what we call downers and uppers, or stimulants and sedatives. So an opioid would be a downer in a way. It would euphoria, a nice. Whereas your uppers, your stimulants like MDMA or amphetamines, would cause you to be a bit more stimulated and it wouldn't cause necessarily respiratory arrest.
Let's go back to the 4 H's and the 4 T's and pick up where we left off. Paragraph 91, please. So tamponade you effectively excluded. Toxins were on your mind in the differential diagnosis. Paragraph 91, the next T is thrombus. For example, a massive pulmonary embolism, blood clot on the lungs that's causing pressure on the heart, causing them to go into an arrest, or a massive heart attack from a blood clot in the arteries that feed the heart muscle. Was there any indication that that was a cause here?
Not from the story. I mean, like we said, the story was limited, but from what I could, from what I've been told there and from the events, I didn't think thrombus was likely. Thrombus tends to be in an older person if they've had a heart attack, and gone into cardiac arrest. PE is an option, but they tend to have had a history beforehand of shortness of breath, chest pain, something else that would have led up to us having an idea if that's what's caused it, rather than suddenly collapsing. The other thing that I think at this point, he may have knew his name at this point, so I would have asked someone to go and look at his records to find out if there was a background of any other things that I needed to know about, any other medical problems if he'd presented to the hospital before.
And did you know his name by this point?
I don't recall, but I do recall asking someone to go and look to see, and I don't think there was anything on our system for him at that time.
Would your system have been updated if you'd received information about his identity?
So if we have his identity, his name would have a CAI number, and that's unique to each person, and they get logged into registered onto our computer system, and then any medical notes for anything that's happened when he's been in hospital would be there. So it would be as up to date as it would be. Yeah.
So if you didn't know the identity of the patient when
I wouldn't
it
have
was
that information.
received,
Yeah.
you wouldn't have that information. And how might details of his identity have come to you?
That would be through the police finding out who he was. There's no way I was doing that at that time. So it'd be the police usually. If we haven't got the identity of a person, then the police will get involved and help.
So in the ordinary course of things, where you have an unknown patient,
Yeah.
in circumstances such as these, if their identity is confirmed by the police, you would expect that information to be fed back to you.
Yes, usually someone would come into the room and say, we've got his name. It'd be honest in saying that my mind is concentrating on what I'm doing at that point. If I was to hear, we've got a name for the person, then I might ask someone to go and look up some records and see if we had any more information about any previous medical history.
And without the name, you obviously
I
can't
can't
make
do that.
those searches. Returning to your statement, the final T at paragraph 92 is tension hemothorax. So that's when the lung has collapsed on one side and is pushing over and you need to decompress it. I don't recall looking in my notes in the A&E records that we did that. I think we had good air entry on both sides when we were bagging him. I don't recall decompressing his chest. Sorry, I spoke.
No, I spoke. So it should say tension pneumothorax. So apologies. So a hemothorax is blood.
Oh yes.
In the chest. It's a tension pneumothorax, which is air. So when the lung is collapsed, you've got air where it shouldn't be, and it's pushing down, and it will cause pressure on the return of the blood to the heart, and therefore causing someone to then go into cardiac arrest. When I was bagging him, Sophie must have listened, and the chest, and I can see the chest rising. So if I can see the chest rising, I know that the lungs are not collapsed. Also his trachea, which is your windpipe, in a tension pneumothorax, it will move away from the side that's collapsed, and it was central. So I was able to rule out tension pneumothorax. We did go back over that later when more people had appeared from the day team, and it was rediscussed, but the anaesthetist had intubated the patient at this point and was happy that he could bag the patient easily. If there's a pneumothorax, you wouldn't be able to bag very well. And also we could see the chest rising, and I think they also did a quick look with an ultrasound, and we decided that decompressing the chest was not in this patient's interest.
So that this T was effectively...
It was cleared,
ruled out.
Yeah.
You mentioned being able to see the chest rising and falling with the bagging. Does that mean that the forced breaths were effective insofar as they were inflating the lungs?
Yes.
And you also mentioned that at some point after the consultant anaesthetist arrived, he was successful in intubating.
Yes, and I remember that being fairly quickly, because if I couldn't... I do remember asking for him very early on, whether it was pre the patient arriving or just as the patient arrived. I do remember asking to phone for him because I knew he was in the hospital having worked together on another patient earlier in the evening, and I knew that I couldn't get the tube in, so I wanted them, and they came very quickly, and I remember him then taking over the airway very quickly and me moving down to the foot of the bed and taking over the running of the arrest at that point. So yes, the patient would have been tubed.
So those were the 4 T's. Let's look now at the 4 H's. If we can scroll down to paragraph 94, please. After checking the 4 T's, we check the 4 H's. Firstly, hypoxia. This is the patient not getting enough oxygen, even though we are using the bag valve mask.
So we use the bag valve. We're giving him oxygen, but the best thing is to intubate the patient. That's the end point. That's the gold standard. So he was tubed early, and he was been bagged properly with a tube in a protected airway. So hypoxia had been dealt with.
Hypothermia is next. Hypothermia is if they've been lying out in the cold or been submerged in water. So if they've got a temperature that's like, it says minus 32, should that be 32?
It should just be 32, yeah.
Then we have to keep warming them up until they're a sensible temperature. Was there any indication that hypothermia?
No indication.
Had here? Okay.
No,
Was Mr. Bio's temperature taken? Do you
It would
recall?
have been taken. I don't recall what it was, but the history didn't lead itself to that either.
All right.
From what,
We've heard evidence that Mr. Bio was lying on the ground, unconscious, wearing a T-shirt on his upper half, only a T-shirt, and that it had been raining.
Okay.
That he lay there for about 8 minutes
Okay.
between falling unconscious and the ambulance arriving. Did you have that information?
No.
Would that be sufficient to cause hypothermia?
It would cause his temperature probably to go down to about maybe 35 and a half, that kind of thing, if it's been about 8 minutes outside. The difficulty is if he was in cardiac arrest, which sounds like he did get CPR on the scene, which again, I didn't know that. If he had CPR on the scene, his body will cool down because he's in arrest, he's not regulating, he's not pumping blood. So it's difficult to say exactly what his temperature would be, but I don't think it would be low enough for me to be thinking about hypothermia as a cause.
The information that I've just shared with you, would it have been helpful for you to have had that information at the time?
It would have been useful in a way to know that he'd had a little bit more CPR before he'd come in. 8 minutes or so isn't a lot, really. Often we have patients that come in who have had about 45 minutes of CPR before they've come to me. It would be useful just to know he had actually been in arrest before he came in, but it wouldn't have changed what I did.
Just to be clear, and nothing may turn on this, I said that he lay on the ground for about 8 minutes.
Yeah.
We've heard evidence that for the first 4 minutes he was unresponsive but breathing. Then he stopped breathing, at which point the officers on the scene commenced CPR.
Yep.
And when the ambulance arrived, I understand that the paramedics continued with the CPR. So it would have been 4 minutes of CPR at the scene.
Yeah.
And then some ongoing efforts to support him in the ambulance.
When he came into the department, there was no CPR ongoing. They were bagging him, but they weren't doing CPR. So what that might give me a hint of is that he might have been in respiratory arrest on scene, but actually maybe still had a pulse, but his output might have been quite low, and people might not be able to feel it, and so quite rightly have done CPR. That would be the right thing to do. But he didn't come in, no one was doing CPR when he came into the department.
I see. Just in case I had misstated anything, we have certainly heard evidence that CPR was given by the officers at the scene. The chair is yet to hear from the paramedics.
Yes.
But I understand that some efforts were made to support him in some way between his removal from the scene and his arrival at the Victoria Hospital. But it may be that nothing turns on that from your point of view.
Yeah.
Back to the H's at paragraph 95. Next is hypovolemia. So they've not got enough circulating blood volume because they've bled somewhere, or they're septic and the distribution of the fluid in their body is not correct. Are there any indications of hypovolemia?
So from a hypovolemia point of view, for him it was trauma that I was thinking about. So that's bleeding into the brain, it's bleeding into the abdomen, it's bleeding into a femur or a thigh bone if it's broken. There's no evidence of that, so that's when we're looking for that. The second thing is a medical cause for the fluid to not be in the right places, which is usually sepsis or heart failure. There was no history of that. Sepsis obviously has a history of leading up to being unwell. It's not a sudden collapse. So the story didn't hint at being sepsis. So trauma, thinking about that and where could he have been losing blood. But there was no obvious blood loss.
You said earlier that having noticed the injury to his head, you carried out an examination of his head to check for any serious underlying injury.
So I would have asked the anaesthetist at the top end to have a look for certain things because I would be at the bottom of the bed at this point. I suppose controlling what's going on because they're doing the airway. So I'd have asked him to have a quick feel and see if he could see anything obvious.
And you, or at least your team, also said, you said earlier, checked his abdomen
Yes.
and the legs.
So the thing with the abdomen you would see in CPR, if you're bleeding out from somewhere, is the tummy will just get bigger and bigger, and that wasn't evident in what we were doing. I don't recall that being evident. I think we even did a fast scan, an ultrasound, a quick look at his tummy, which would be looking for free fluid in a trauma setting.
You mentioned earlier in your evidence that something like a broken femur can in fact be sufficiently traumatic to cause an arrest.
You can lose a lot of blood in a broken bone very quick in your femur very quickly.
And the femur is one of the leg bones?
It's the big thigh bone, yes.
We've heard evidence that fast straps, long Velcro straps, were used to bind Mr. Bio's legs at Hayfield Road. Were they present when he was brought into A&E?
I don't recall, but I know my statement has said, the first one has said that there were straps on his legs, but I think I took them off.
You think you took them off?
Yeah, I'm pretty sure I would have taken them off to look at his legs.
Would they have got in the way of you examining his legs for injury?
They're usually at the feet, and I'm looking more at the thigh. That's where I'm going to be seeing if there's any blood loss, but I would want to look in between the legs to see if there's any bleeding from there as well. So yes, they would get in the way for looking properly at the body.
We may have heard evidence that they were applied either just above or just below the knee.
The knee, okay.
If that were so, would they have got in your way?
Yes.
So they were. You might not recall this now, but you say you saw it in your PERC statement, and you removed them.
Yeah.
Okay. Back to the H's, the final H's, hyperkalemia. This is if their potassium is too high, and that can be from kidneys that don't work properly, sepsis, drugs, lots of other reasons. This can cause a patient's heart to go into arrhythmia and cardiac arrest. Were there any indications that was a potential cause?
If he had a background of being a patient who had renal dialysis, obviously I didn't know that based on the history, but if he was a patient who was on renal dialysis, then I would see something called a fistula on him. So I would be able to say, this is somebody who gets dialysis, we need to check his potassium, because their potassium can get too high and cause them to have arrhythmias and arrest. That would be one thought in any person. The other thought from hyperkalemia, that tends to be the main thing, or if they're unwell previously with sepsis, etc. What we do very quickly is a blood gas, and that gives us an answer what the potassium is within a few minutes, and we can say whether, it's very high, let's treat that or not.
And a blood gas screen, I think, was carried out in this case. And were there any indications that there was anything wrong with potassium levels?
The potassium, from what I can recall, was normal.
So would that exclude that as a
It would exclude it, yes. It has to be, you'd have to have a potassium above 6.
So you have effectively excluded all of the 4 T's and 4 H's with a perhaps question mark over toxins, but the remaining 7 you have excluded. And you said earlier in your evidence that having gone through that checklist, you started to think about trauma in more detail and about the possibility of a potential drug-related cause of the arrest, hence the prescription of naloxone. You mentioned in your statement 2 cardiomyopathy, if we can look at perhaps paragraph 74 very quickly.
I was kind of trying to think of other things.
Paragraph 74, you say another possible cause I considered was an underlying medical problem like cardiomyopathy, which is an enlarged heart. The patient may or may not know about this. The heart can go into dysarrhythmias that sometimes people don't know until something bad happens.
Yes.
And at paragraph 75, you say, ultimately, I don't know what caused the patient's cardiac arrest. My gut feeling at the end of the arrest was it was most likely to have been drug-related. I knew no history of his background. So if he has no history of drug use, then I would think it wouldn't be drug-related. But obviously I didn't know that at the time. I have to go with what's in front of me.
Yep.
And in terms of what was in front of you, you had the patient and his presentation, and he was a young person.
Yes.
And you've explained that misadventure is one of the more common causes of arrest in a young person. And you had a history that was relatively limited.
Yes.
And indeed you say at paragraph 76, I had to think about all these possible causes because it was not a clear story of what happened before the patient came in to A&E. Can we look again at the medical records, please, page 7? So the clinical examination hasn't revealed an obvious cause for the respiratory or cardiac arrest, and there's a limited history available to you. Let's remind ourselves of the information that you had. Found by police with knife, aggressive, attacked police officer, pepper gas used and uncooperative, hit on back of head, then was in respiratory arrest with ambulance crew. Now, I don't see any mention in your handwritten notes, Doctor, of Mr. Bio having been restrained by the police.
I don't think I had been told that at the time. I mean, I know he's cuffed and he would have had the bands on, and I presume if I've been told he's been aggressive, then I presume that's what they've had to do. But that, I don't recall going into detail, and to be honest, when he comes in and he's in respiratory arrest, getting a lot of detail at that time, I'm trying to think of what other things to do, so I don't particularly want them to give me a whole big long story, because I need to do stuff.
You just need the essentials. But there isn't any mention there of him having been taken to the ground and restrained for a period of time, or the position of the restraint?
Not at that time. I suspect maybe afterwards somebody maybe told me a bit more, but at that time I don't recall being told anything other than what I've written here.
And you perhaps have no recollection then of being told whether he was resisting a restraint or whether force or weight were being applied to his body on the ground?
Not that I remember, no. I don't know. I mean, all I've been told is that he was aggressive, and that's, I don't recall anybody telling me that they'd had to pin him to the ground.
And if you had been told something like that, would you have written it down?
Yes.
Would you have found it helpful to have had that information?
It can be useful, because it depends if he was pinned down face down or on his back. So sometimes if you're pinned face down, that can cause asphyxiation, so it can cause it if they're being pressed down, so they're not necessarily able to breathe properly. So it would be useful to know that. If he had to, I mean, I know I've documented he got hit in the back of the head. It would be useful to know, had he then fallen to the ground? He was a big guy, that's quite a height to fall. So yes, it would be useful to have a bit more of what had happened previously. But
quite a lot of evidence has been led about the position of the restraint and what the different officers involved in the restraint were doing. But there's certainly some information for the chair that he was held in the prone position, and that the way in which he was restrained has been described by a number of witnesses in a number of different ways, but just yesterday was described by a witness as looking like a collapsed rugby scrum. Would you have found that type of information helpful?
yes.
What difference, if any, would it have made to your assessment of the patient's condition?
So prone position in somebody who has potentially got alcohol and drugs on board can restrict their breathing if they're being compressed down on the ground. Well, it can anybody, to be honest. It doesn't have to just be somebody, but if they've also got other things on board, that will affect their breathing too. But if they are being pushed on the ground, it can, if they're in a prone position, that could affect their breathing.
So what difference, if any, might it have made to your treatment of Mr. Bio?
It wouldn't have changed what I did, but it would have given me a bit more information as to what potentially could have caused him to go into respiratory and cardiac arrest.
And how would it have helped you in your practice of emergency medicine to have had that additional information about potential causes?
To be honest, it would just have given me a bit more information about what could have caused the respiratory arrest, and then to go into cardiac arrest. It wouldn't change my management at all, because there's a set way I would manage this, and as I've laid out. So it's not going to change what I do, but it would give me an idea of what has led up to it, rather than me necessarily having to think of everything under the sun that could have caused him to arrest. It would have given me a bit more, okay, so that's happened, that might have led to this. But I would still be going through all my 4Hs, 4Ts, etc.
Doctor, there's one final thing I want to ask you about before we go on to discuss the treatment of this patient, and it's the possibility of sickle cell anemia. And I wonder if we can turn to paragraph 77 of your inquiry statement. You say, Sheku Bio, being a black man, had no impact on the assessment or treatment, However, the only thought I might have considered is that sickle cell could be a cause. Sickle cell is a hereditary disease that is in some black people. It's when the blood cells have a sickle shape to them. You can either carry the gene with the sickle cell trait or you have sickle cell itself. It basically means that the body doesn't always carry oxygen as well as it could, and therefore you can have crises. These crises can be bone crises because you've got occlusions because of the sickle cell sticking, or you can have chest crises. For it to apply in this case, Checo would need to have been unwell medically beforehand. He would need to have had a different presentation to what was reported to us. It would be a slow deterioration in his health. You would need something like chest pains for a time and become more unwell before going into cardiac arrest. It doesn't fit with this situation. So do you recall thinking about sickle cell as a possibility at the time?
Because he's a young person, you're trying to think of everything you can attend to. What could have caused this? What can I do to try and get his heart to restart? So you do end up thinking about what we call the zebras, I suppose. So you're thinking the horses are the most obvious things that cause somebody to go into a cardiac arrest, but you're trying to think of other things. What am I missing? What could I be thinking here? And that popped into my head as is this a cause? But clinically it didn't fit with the story, and also whether we knew who he was at that point, we would then know if he had that in his background, because it certainly wouldn't have been the first presentation, because it's something that can happen throughout your life.
So again, if you had known the identity of your patient,
yes,
you could have checked his records and confirmed a history, one way or the other.
Yeah.
Let's move on to the treatment of this patient, Doctor. And we were talking about the A, B, C, D, E, and you explained you got as far as the questions. Again, just to make sure that we all understand the terminology there. What is meant by a rhythm?
So a rhythm would be looking to see if the heart is got an electric rhythm. So there's two ways. You put the pads on the patient, you look at the defibrillator monitor, and that will tell us. It can either be not a flat line like you see on the telly, but a kind of a squiggle that lets us know they're in something called asystole, so there's no rhythm there. It can be in something called pulseless electrical activity, which it looks a bit like a normal rhythm, but there's no pulse, so it's a kind of rhythm but not a shockable one. And then you've got two other rhythms that we would look at, which are ventricular tachycardia and ventricular fibrillation, and that is when, and so in VF there's no real organised rhythm on the screen, you're just seeing basically lots of squiggly lines is the easiest way to explain it, and that would let me know, okay, you're in VF, I need to shock you. And VT is another type of rhythm and is slightly different to VF, but again it would be a shockable rhythm.
Okay. What's the relevance of a rhythm being shockable or not?
So if a rhythm is shockable, ideally you want to do early defibrillation. Chain of survival is early recognition, early CPR, early defibrillation. If they are, we want to recognise that straight away. So the first thing I would do when the patient, if I recognise they're in a cardiac arrest, is get the pads on and look at the rhythm. I would start CPR, look at the rhythm. It's a shockable rhythm, right? Let's get electricity, because the sooner you apply that shock, the more likely you are to get them back into a normal rhythm and restart the heart properly.
So do I understand correctly that it's the electric shock that gets the heart going again?
So it kind of, it takes over, or it restarts it, so a sense, because the heart has got it's fibrillating, so it could, if you were to open up the chest and in VF it'd be going like this, so applying the electric shock kind of gives it a restart, it's like the on-off button to re-switch it back into going into a proper rhythm, or normal sinus rhythm.
So for a successful outcome then, the rhythm needs to be a shockable rhythm.
So the algorithm splits into shockable and non-shockable, so it has to be a shockable rhythm for us to give electricity. If it's not a shockable rhythm, I can't give electricity.
If the rhythm isn't shockable, is there anything more that you can do for the patient?
If it isn't shockable, then we go down a different algorithm where we continue CPR, you give adrenaline every second cycle, and you then think about your reversible causes and you try and see if you can get the heart to restart. After a certain period of time, you have to then make that decision to say it's time to stop.
Okay, and is that, we will look at this in more detail, but that is essentially what happened in this case?
Yes.
Let's return to your statement, please, at paragraph 83. And this is your explanation of the algorithm that you've mentioned. Our cardiac arrest algorithm is CPR for 2 minutes and then do a rhythm check. This is repeated Each time you do a rhythm check, you're looking to see, first of all, if there's a pulse. So if you got what we call return of spontaneous circulation, or you're looking to see what the rhythm is on our machine. We had pads on his chest, so we're looking to see what the rhythm might be. On 3 occasions, his rhythm was VF. We then gave 3 shocks, so we're looking at the rhythm, and we're also looking for whether it's a shockable rhythm or not. So this all relates to CPR, which is cardiopulmonary resuscitation. And you explained earlier that the pulmonary element with the ambubag and the forced breaths. What's the cardio element? How are you actually
So that's the compressions. That's the cardiac part is the compressions. So they would be done manually to begin with, and then I think we got the Lucas machine out to do mechanical ventilation to free people up.
And I think I recall you saying earlier in your evidence that the pattern that you work to is 30 compressions?
30 compressions to 2 in an adult.
To 2 breaths. Yeah. And that's repeated how many times in a cycle?
So you would do that for 2 minutes, which is usually 5 cycles, and then you would recheck. What I mean by return of circulation or signs of life is at the 2 minutes you check the pulse and you'd look at the screen. If the patient starts moving around, then obviously there's something has started, so then you go back and reassess from your ABCDE. If you've got checking for a pulse and you're looking at the rhythm, there's no pulse, but the rhythm has changed to a non-shockable or it's still shockable. So if say it's still shockable, you'd then deliver another shock and then continue CPR for another 2 minutes.
Right. You said that the compressions are manual, but you also involve the Lucas machine.
Yes.
And we've heard evidence already from a nurse who was involved in using that machine. And you say, I think, in your statement that you don't specifically recall the machine being used.
Yeah, it's one of those things that we would ask for. There's certain things as I suppose as a senior running the arrest that you know you'll have asked for, you just don't necessarily recall because it's habit and it's what you would do. But ideally you want to get manual compressions done so you're freeing up people so that they can get other tasks done. And also CPR is very tiring and you'll end up going through everybody and you don't then deliver as good CPR. So getting him onto the manual machine is in benefit for the patient and for the team.
If we can jump to paragraph 45 of your statement. Sorry, paragraph 44 first. And this is your explanation of how this machine works. You say a curved board goes behind the patient's back, a band goes across the chest, and a big sucker device hits onto the chest. A suction thing makes contact with the chest and sucking onto the chest. It's loud and you can hear it from nearby. Patient's arms are moved out of the way. So that's an explanation as to how it actually mechanically functions. Yeah. So it's a suction device then?
Yeah, so it doesn't sound very nice, but it's basically a piece of machinery that's got a big suction in the middle, and it clicks onto a board that goes on the back of the patient, and then there's straps that the arms get put into so that they're not on the flapping around. They get put onto there, and then the machine will do the compressions for you.
And does it compress at the same rate as if you were doing it manually?
It's better than manual compressions. It's set to go at the same rate and the same depth as what we should do, but obviously we're human and make more error and get tired. The machine does not, so it does a good job.
Paragraph 45, you explain it should connect in the middle of your breastbone, probably about 2 or 3 inches down from what we call the sternal notch between the 2 collarbones. It's over the heart, so you're wanting to do manual compressions of the heart. We use the machine to compress the chest and squeeze the heart, so it's doing its job, pumping blood. Now, can you help me by pointing to the sternal notch on your own body?
So the sternal notch is here, so it's like that wee bit there. And then the compression should be more here. So it's in your 5th intercostal space, so it's further down. It's about there.
So you're pointing to the middle of your chest, and if I remember well, the nurse who gave evidence described the location as being sort of in alignment with the nipples, essentially. Yeah. Would that be correct?
Yeah. All right. Yeah, we call it the 5th intercostal space because that's basically where the heart should sit on the left side. So it's about there.
But for a layperson, that would be
the middle.
A fair description. If we can move to paragraph 55, please. The inquiry may hear evidence in the fullness of time that a fracture of the first rib was detected at autopsy. And you explain in your statement that you would expect to fracture some ribs from CPR and using the Lucas machine. If you're doing proper CPR at the right pressure, you will usually crack ribs. The ribs that would break are usually from rib 4 to 8. You've got rib 1 at the top, and then you count down the chest. You've got 10 that are attached, and then you've got 2 floating, so you've got 12 in total. 4 to 8 are in the middle at the front. Again, by pointing to your own body, can you indicate the position of the first rib?
First rib's up here, so way up at the top.
So I can't quite see your fingers through your jacket.
It's probably kind of about up here, the first rib.
Okay.
It's kind of underlies just under your collarbone.
Just underneath the collarbone.
So it's up here, the first rib.
Here. All right. And ribs 4 to 8, where are they?
They would be a bit further down. It's not linear, if that's what I'm trying to say, because the ribs will curve round and up. So it's not like a line that they go, they do curve round. So 4 would be here, but 4 at the back would be a bit higher up.
All right, but at the front again, you're indicating...
Be in between the nipples.
Okay, so roughly in the same alignment as where you would place the Lucas machine. And sorry, is it rib number 4 that's in that alignment, or is it all of 4 to 8 that are in roughly that alignment?
It was more of an estimate of what I thought, if you were to have the device. So it's probably, if you're putting the device in the right place, you're going to be compressing over ribs 4 and lower.
Now, some evidence has been led that there was difficulty positioning the machine, but to the extent that it may have been wrongly positioned, it was positioned lower down than it should have been.
I don't recall that.
But if you work with that hypothesis, what impact, if any, would that have on the likelihood of higher ribs being broken during the use of the machine?
Make it very unlikely to break a higher rib.
In paragraph 57, you say it would not be common for rib 1 to fracture in the course of chest compressions. In CPR, you're talking ribs 4, 5, 6 and further down. To break up at rib 1, you have to press higher up at the top. It's not inconceivable because you can't say in medicine that anything is absolute apart from death. Realistically, you can't say breaking rib 1 in CPR is not a possibility.
So what I mean by that is if you've got a little old lady who's osteoporotic and you're doing CPR, which is pretty aggressive procedure, then it's not totally inconceivable that you might crack a whole load of ribs that you don't necessarily expect to. On a gentleman like this patient, it's very unlikely to cause a fracture of the first rib.
So returning to your treatment algorithm, can we go back to paragraph 84, please? Where you explain that on 3 occasions Mr. Bio's rhythm was ventricular fibrillation, so he was shocked on 3 times. So you were looking again at the rhythm and looking at whether it was a shockable rhythm. And in paragraph 85, you explain that drugs were given to try and stabilise the rhythm, that he was given amiodarone and adrenaline, and the purpose of those drugs is to try to stabilise the rhythm. Is that correct?
Yes.
Yes. Yeah. And finally, paragraph 97. Having refreshed your memory by reference to the records, you say the patient was in ventricular fibrillation at some point and you shocked him, but it didn't do anything. What do you mean by it didn't do anything?
So it wouldn't have put him back into a normal sinus rhythm, so what it basically it's not worked. He'll still be in the VF, and then as we continue CPR, the VF will change into a non-shockable rhythm.
3 episodes of VF rhythm. We continued to do what we would do normally in the algorithm. The patient's heart then went into a non-shockable rhythm, so we kept doing only CPR and giving him adrenaline every second cycle.
Yeah.
Was that all that you could do at that stage?
Yes.
Can we look briefly at the blood screen that was carried out at paragraph 106? You mentioned taking venous blood gas reading, and paragraph 106 explain that you were looking to know how much acidosis is in the blood system from the arrest and how much will be reversible, because you can get an idea of the prognosis. And you say that the hydrogen ions, which is what you work with, were not compatible with life as acidosis was very bad. What is acidosis, Doctor?
So it should be hydrogen ions, not irons, or the R. Sorry.
Ions, I see.
Just,
I see. That's just a typo.
Sorry, it's just a typo. So acidosis is an accumulation of acid in the blood, which will mean that the normal regulation of organs and the conditions that the organs and the cells work in are going to be affected by the amount of acid, and it will damage them, and it can damage them beyond repair.
What would cause that?
So going into cardiac arrest can cause that. So your body you're not getting oxygenated, you're not getting blood pumping round, so your body is it's shutting down, or it has shut down, but things are not working properly or aren't working, so therefore the acid will build up in your blood, and that is quite normal in a cardiac arrest to have that. When we look at the blood gas when we're running arrests, we look to see what the hydrogen ions of the pH are, and it gives us an idea of potentially how long has this person been down before they came to us, etc. So yeah, I don't quite remember what the question was, sorry.
I was just asking about acidosis and what might cause it, but I think you've answered that.
Cool.
Can we move on to paragraph 109? You explained that another screen that came back from the blood test was lactate, which was very high, and that people who have that kind of high lactate have a very poor prognosis for survival. Again, what is lactate?
So that's a product of when you're not oxygenating tissue, so you'll produce lactic. And it's kind of lactic acidosis, they kind of go together, lactate and acid. But the pH, or the hydrogen ions and the lactate, in certain cases like seizures or cardiac arrests or sepsis, let us have an idea of the likelihood that we can reverse this, or what the prognosis is likely to be.
So you have a patient who is now in an unshockable rhythm. You've been able to take a blood test. Can that be done very quickly at the bedside?
Yes, so you can take the blood test usually from the femoral artery in the groin. The blood, you can take blood from somebody who's dead quite a few hours afterwards from certain vessels that will still have a bit of blood that hasn't clotted. So in an arrest, we usually go for the femoral artery because we can do a stab and get blood straight away, and that gives us information.
So this isn't a situation where you have to send the blood to a laboratory and wait any period of time. You can do this very quickly.
If I remember rightly, Sophie got access very quickly, and I would have asked for a gas straight away because it gives me an idea, i.e. for the potassium. And then I think we repeated his gas later on a couple of times just to see how things were going.
And certainly by the time that the patient had an unshockable rhythm, the information that you also had was that the lactate suggested a poor prognosis. And
the hydrogen ions of over 200 and a lactate of 18 is not compatible.
Not compatible with life. The blood samples that were taken, we're aware that some blood was seized at the hospital and later subjected to examination. Can you help me with whether the blood samples that were taken in the accident and emergency department were taken before or after drugs were given to Mr. Bio?
They would be taken. There's two thoughts here, so apologies if I don't know if the crew had put a cannula in, the paramedics put a cannula in prior to him coming in. I suspect they did because that would be their normal practice. If that's the case, then I probably would have used that one for the Narcan or the Naloxone. However, Sophie did get a line in straight away on the other side and would have taken bloods off at that point. So if he had been given Narcan, which is very short acting, it wouldn't necessarily have affected the bloods that we took. But we also could have given Narcan through the drip that Sophie had just put in, and of course the bloods would have gone out before that. So the only drug that I gave him, I think, was adrenaline, amiodarone and Narcan, and they shouldn't affect what blood tests would then, or that I know of anyway.
We might...
Johnson, I would like to interrupt Mr. We usually have a break, particularly for the sake of the stenographer, after an hour and a half. So would this be a convenient point to take a break?
It would, sir, although I can advise that I only have one final topic to explore, and really, yes, in fact, I think on reflection it would be advantageous to break at this stage if that's convenient.
Yes, well, we'll have a 20-minute break at this point. Yes, Ms Thompson.
Thank you, sir. Doctor, before the break, I was asking you some questions about blood samples that had been taken from Mr. Bio, which ultimately were, the chair may hear, were uplifted by the police and sent to a laboratory for screening for drugs and alcohol and so on. And you may not know the answer to this question, but I'm keen to understand whether those blood samples would have been taken immediately upon his arrival in A&E and before he was given fluids or any drugs, or whether they might have been taken after fluids or drugs had been given.
They would have been taken fairly quickly, within 5 minutes of being in the department from going into arrest and asking for someone to put a cannula in. So the bloods would have been taken quickly, because I do remember Dr Rowlings getting a cannula in very easily. It would have been before any drugs that we gave. I can't say for drugs that the paramedics will have given.
Sure. What about fluids?
Maybe before fluids.
Before fluids too. Doctor, there are a few questions I would like to ask, having simply reflected over the break on the evidence that you gave this morning, and they're in no particular order. And then there is one final chapter that I would like to explore with you before I conclude your examination. Once a patient has gone into respiratory arrest, can you say how long it would be before cardiac arrest would occur if the respiratory arrest were not reversed?
About 5 minutes. It would be pretty quick.
You mentioned having access to the anterior crucible fossa?
Anterior cubital fossa.
Cubital fossa, I beg your pardon. And you explained earlier in your evidence that the presence of the cuffs may have impeded that access. Where is the anterior cubital fossa?
It's here in your elbow, where you bend your elbow.
So that's the inside crease of the elbow. Do you mind my asking what height you are, Doctor?
5'5".
You had been made aware by the paramedics at the time that you received Mr. Bio that he had been sprayed. Would it have made any difference to how you assessed or treated him if you had been told that he had been sprayed by 3 separate officers with both CS spray and PAVA spray?
Not necessarily. If he'd been conscious, then the spray in his eyes would have meant we'd have to have done eye washouts. For the fact that he'd gone into cardiac arrest, it wouldn't change what I did, and it's not, that doesn't cause cardiac arrest. It's more to de-escalate or to stop somebody from doing things.
Earlier in your evidence, you said that it may have made a difference when the police were carrying out CPR if the cuffs had been removed. What difference might that have made?
It would have just been better contact with the hand in the space to compress on the chest. If the space was small and the person who was doing CPR had a big hand, you might not have got quite into the space as well, but unless I saw it, it's difficult to say. But basically it's about getting your hand right into the space to do good compressions.
And if you're not able to get your hand right into the space, either because of the presence of cuffs or potentially because the person giving CPR has big hands, then what impact does that have on the quality or the efficacy of the compressions given?
It could reduce the efficacy or the quality of it.
What might be the overall impact of that on the CPR given?
It just means you're not giving good compressions, you're not pumping the heart manually to spread blood around the body, therefore you're not giving effective CPR, and it's not necessarily going to help get the heart to restart.
Finally, Doctor, I'd like to ask some questions about the decision to pronounce life extinct. How was that decision taken?
So that decision is based on the amount of time that you've been working on the patient. It's based on the acidosis and the lactate from the gas. It's based on the reversible causes, or what we think might have happened to cause the cardiac arrest, and it's made as a team.
So it was a team decision?
Yes.
Who's involved in making that decision then?
So it's usually the leader of the team will bring up the subject, will say, I think we're at the point where we're not getting anywhere, we're not able to restart the heart, there's no reversible cause. Are we all in agreement that we should stop?
Can we look at the medical notes, please? Page 10. If we can scroll to the bottom of page 10, please. Do we see PLE team agreement at 0904?
Yes.
PLE is short for?
Pronounced life extinct.
So the team reached that agreement at 9
Yes.
in the morning. Now, Doctor, when we looked at page 7, we saw that you had written up the notes retrospectively at 0900
Yes.
hours. Were you still at the bedside at this point in time?
No.
Or no?
What had happened was about 10 minutes before pronouncing life extinct. At this point, my consultant was in the department and was I'd handed over to him, and the day team registrar was there, Dr. Anderson, and there was the ITU consultant and the anaesthetic consultant. So just before 9 o'clock, I had said to Dr. Surinder, was the consultant A&E, and had said, I think we're at the point where we should stop. We've been going for over an hour and a half. In theory, if he'd come in just about 7:30. We've not got any reversible causes. We're now at an acidosis of 213. I think we should stop. He agreed. However, Dr. Clark, the anaesthetist, did not want to stop at that point. He wanted to keep going for a bit longer. And I understood why. It's a young man. We want to see what we can do to do our best. So at that point, I decided to step out and go and write the notes and let Surinder and Dr. Clark decide when to stop.
You had explained at the beginning of your evidence that Mr. Bayer was brought into A&E shortly before the shift handover.
Yes.
Which I understand was at 8 o'clock in the morning?
So the nurses handover at 7:30, and at that, I remember this purely because a nurse I know had said something about seeing somebody out in the street, and then the box went off, and we knew, well, she had said, I bet it's that person I saw. So I recall it being just after 7:30 because it was the nurse change, and then the doctors come in at 8 o'clock for the handover at 8 o'clock for them.
Did your handover happen at 8 o'clock?
No, no, we were busy doing this.
Okay, so this would prioritise, this would be your
absolutely.
priority.
Yeah,
And
the handover, so there was another junior SHO, Dr Gillies, who was on the day shift, so I think she went and took the handover from the other doctors who were on the night shift, whereas myself and I think Sophie actually had gone off to do that as well. However, I stayed with Surinder and Dr. Anderson with this patient.
so your work is the priority over the shift handover? And
But yeah, this patient was the sickest patient in the department, so you stay with them.
All right. And you said you stepped out at about 9 o'clock to write up your...
I think I stepped out just after we had
notes.
had a discussion about stopping, and I stepped out at that point and let the seniors decide when they wanted to stop.
Should we understand that was because there were doctors who were senior to
Yes,
you
yes.
now involved in the resus,
Yes.
including 2 consultants?
Yes.
That's Dr. Panther, the A&D consultant,
Mm-hmm.
and Dr. Clark, the consultant anaesthetist.
Yes.
Is that right?
Yes.
You also mentioned that the doctor who would be replacing you on the day shift was also now present.
Yes, Dr. Anderson.
So in those circumstances, was it appropriate for you, although you'd been involved in the resuscitation and leading the resuscitation, to step away and to allow others
Yes.
to take
So,
over?
as the senior overnight, yes, I'm the one running it, but when my consultant comes in, he will be there with me and let me continue to run it, or I hand over and let him take over. I think at that point it was appropriate to say, I think you take over now and step out.
You said that at about 7:30 it was the nurse's handover,
Yes.
and you recall one of the nurses saying that she'd seen the patient earlier that morning.
She didn't know it was the patient that we were also going to get, but she had said that on her way to work she'd seen somebody on the street with a knife. the box, about a couple of minutes after saying that, the box went off saying that we were getting somebody coming in, and she said, "I bet that's that person I saw." That's why I remember it.
Do you recall the name of the nurse?
No.
Do you recall a Linda Limbert being on shift at that time?
It's a name I know, so it probably was, but yeah, it would be 7 years ago.
Dr. Pickering, is there anything more that you or your team could have done to save Shekobayo's life?
No.
Bear with me just a moment, please. Sir, that concludes my examination.
Thank you. Are there any Rule 9 applications in respect of this witness? Ms. Mitchell. Dr. Pickering, I wonder if you would withdraw to the witness room while I hear a submission.
Okay.
Yes, Ms. Mitchell.
I'm obliged to both counsel to the inquiry in respect of the Section 9 and also other questions which that have been asked, but there are just one or two that remain. The first issue arises as a result of the witness saying about needing quick access to the veins to start giving drugs. The inquiry may come to hear quite shortly that the paramedics couldn't get an IV in to give Mr. Bio drugs because he was handcuffed. And what I'd be wanting to ask the doctor was, what are the drugs that would be given when the IV goes in? And what is the effect on delay in giving those drugs? Because she stressed they were of importance. She expressed the view that speed was important. And the next was that the witness gave evidence about someone in a prone position who's potentially got alcohol and drugs on board that can restrict their breathing. She talked about if they were also being compressed to the ground, and her outcome was that if they're in a prone position, that could affect their breathing. And the question we would like to be asked was, could it cause respiratory arrest? The final issue is in respect of the rib breaking, the first rib breaking, and the inquiry has heard evidence that in relation to Mr. Bio, it was unlikely to have been the cause of the first rib giving CPR. And what I want to ask, as the witness has expressed a view on whether or not CPR is likely or unlikely to cause the fracture of the first rib, to ask the witness whether or not the 3 police officers restraining him and the combined weight of the 3 officers, might that be a more likely cause of the fracture of the first rib?
Yes, very well. I shall allow you to ask these questions. If you could perhaps rearrange the seating so that the witness can be brought back in. Dr. Pickering, you're going to be asked some questions by Ms. Mitchell, who's the Queen's Counsel for the Bio families.
Okay. Just a few questions. The first is in respect of some evidence you gave earlier about putting in an IV. Mm-hmm. And the inquiry may come to hear evidence at a later stage that the paramedics couldn't get an IV in to give drugs because of the handcuffs.
Okay.
And what I was wondering was, when you get the IV in, what are the first drugs that are being put in?
So if he was still in respiratory arrest and not in cardiac arrest, I probably would have given naloxone fairly quickly to see if I could reverse the effects of whatever had potential, if it had been opioids that had caused the respiratory depression. In the cardiac arrest, it would be adrenaline. In the non-shockable rhythm, it would be every 2 minutes. In the shockable rhythm, it would be after the third cycle, along with amiodarone.
I think the first two of the drugs that you've spoken about are in fact ones that, again, the inquiry will come to hear, were considered by the paramedics. What you explained that you want access quickly so you can start giving the drugs. What is the effect in each of those circumstances on delay in giving those drugs?
So it means it just makes it harder to get the heart to restart. If you want to give adrenaline early, there's an ethical debate over doing studies where you give a placebo or give adrenaline to find out whether it does do the job that we think it does. Obviously that hasn't necessarily been approved yet, but the idea is giving adrenaline early will help to restart the heart, and the amiodarone helps to restabilise a heart that's in an irregular rhythm. So it is important to give them early, but if it's a shockable rhythm, the shocking is more important.
And if it's not a shockable rhythm?
Then it's getting the drugs in as quickly as you can, and that's why you give them every second cycle.
And do we take from that that the faster the drugs are in, the more likely is?
Yes, it will help. It does help. Yes.
The next issue I'd like to move on to is to pick up on something you were talking about earlier about Mr. Bio when he was in the prone position, or it was put to you, and you gave a comment about that, and you said, so prone position is somebody who has potentially got alcohol or drugs on board can restrict their breathing if they're being compressed down on the ground. Well, it can be anyone, to be honest. It doesn't have to be somebody. But if they've also got other things on board, that will affect their breathing too. But if they are being pushed on the ground, it can, if they're in a prone position, that could affect their breathing.
Yeah.
Could that circumstance that you've described cause respiratory arrest?
Yes.
Moving on then to the next issue. The next issue is in relation to the breaking of the rib, and we've heard your evidence about the breaking of rib 1 and the likelihood of Mr. Bio having suffered that breakage as a result of CPR. And I think you gave us the example that if you've got an older woman who's osteoporotic and you've got aggressive CPR, then it's not inconceivable, but your view was on a gentleman like this patient, meaning Mr. Bio, it's very unlikely to cause a fracture of the first rib. The inquiry has already heard evidence that there were 3 police officers on Mr. Bio when he was in a prone position, restraining him, pressing him to the ground. These 3 officers were 13.5 stone, 20 stone and 25 stone. So a considerable weight was involved. Might that be a more likely cause of the fracture of the first rib?
It could, yeah.
Well, Dr. Pickering, thank you very much for coming and giving evidence to the inquiry. I'm going to rise to allow the introduction of the next witness, and you'll then be free to go.
Okay.
Now, Ms Graham, the next one is Constable
PC Daniel Gibson.
Gibson. Good afternoon, Constable Gibson. You're going to be asked questions by Ms Graham, whom I think you've already met. Before that, would you say the words of the affirmation after me, please? I solemnly, sincerely and truly
I solemnly, sincerely and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Ms Graham.
Thank you. Good afternoon, Constable
Good
Gibson. Do you want to give us your full name?
Yes, my name's Daniel Gibson.
And what age are you?
I'm 32 years old.
Thank you. And how many years service do you have now?
So now I just have over 10 years service.
And you were fully qualified in 2015.
Yes.
Thank you. And we have your contact details available to the inquiry, so I won't be asking you to say those out loud. But have you managed to watch any of the other hearings that we've had up till today?
Yes.
So you'll know that I want to make sure you're as comfortable as you possibly can be.
Yes.
And there's a black folder in front of you. And you'll have seen from other evidence, if you've watched that I'll be referring to your inquiry statement that you've given us.
Mm-hmm.
And you should have hard copies of that in the black folder.
Yeah.
And you must feel free at any time to have a look at that. Now, when I bring up particular paragraphs on the screen, you might want to look around other paragraphs, and just feel free to do that if you wish.
Okay, grand. Thank you.
And let's do that then. Can we have also a look at the statement from the 4th of June 2015, please? And this is Perk 258. And you'll see that this is a statement that you gave to Perk on the 4th of June 2015, and that's on the first page.
Yep.
So you'll see it on the hard copy, but you'll also see it on the screen as well.
Yeah.
And that was a statement taken by investigator James Bonner and DSI Edward Miles.
Yeah.
And that was at your home address. And can we just confirm you were doing your best at that time to give a true and accurate record of the events of the 3rd of May 2015 to Perk?
Yes, I was.
Thank you. And in addition, there was a map that was available, and that'll come up on the screen. And this was also given. And this is COPFS 99. And is that you'll see at the bottom left-hand side, that's got your name, but it's just slightly below the screen, but it says PC Daniel Gibson. Do you want that to move
Oh,
up
I
a
can see it
little
now.
bit?
Yeah.
You can see it. And that was the 4th of June 2015.
Yes.
Was that prepared by you?
I can't remember it, but
Yeah.
it does look possibly like my writing, to be fair.
All right, that's lovely. And you may have seen with other witnesses that I've confirmed with them that if the chair is hearing evidence from you today and seeing your inquiry statement, if there's any difference between that and the statement you gave to Perk in June of 2015, which should he prefer?
I would say you should prefer the Perk statement. That probably would have been fresher at the time.
Lots of people have already told us that their memories were fresher in 2015 than they
Yeah.
are now. Is that the same with you?
Yes, I would say so. Yes.
All right, thank you very much. And then let's have a look at your statement. This is SBPI 45. Now, it's headed up Response to Roulet Request. And as with other witnesses, you were sent a large number of questions from the inquiry team.
Yeah.
And then you prepared this statement yourself in response to those questions with your lawyers.
Yes. Yes.
Thank you. And I'm going to call that formally it's a response to a Roulet request, but I'm going to call that your inquiry statement today.
Okay. Yeah. That's
Thanks. And again, can we look at the final page, please? And the inquiry team asked you to add in a paragraph at the end of this statement. You'll see that. I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry and be published on the inquiry's website. So you understood that at the time?
Yes.
And although we can't see it on the version on the screen, you'll see that you've signed that on the hard copy that you have in front of you.
Yes, that's correct.
And can you tell me the date that you signed it? Is it the 15th of April 2022?
My side's not that good, look at this.
Oh, don't worry. I think you can take it from
yeah.
me. It was the 15th of April.
I could just say that, yeah, 15th
Yeah,
April. Yeah,
that's lovely. So those are your statements in the black folder.
Yeah.
Now, as well as that, there should be a spreadsheet in front of you.
Yep.
Let's have a look at that for a moment, just so you know what it is. So it's a combined audio and video timeline. And you'll see on the left-hand side that there's lots of timings given in the 24-hour clock.
Yeah.
So it gives the hour, the minutes and the seconds. And then to the left of centre, it talks about airwaves transmissions, and it gives a sort of transcript of those.
Mm-hmm.
And then to the right, there's a sort of thumbnail sketch of what can be seen in CCTV.
Yeah.
And it's a combination. And again, if you watched any of the hearings up till today, you've probably seen that on the screen.
Yeah.
That's the combined footage with the real-time clock and the CCTV and a reconstruction tile. Have you seen those?
Yes, yes.
Great. So you'll know that you can touch the screen when we're talking about that and put a red circle or an arrow.
Yeah, I've seen some.
You're quite
officers
comfortable
do
with
yeah.
that, right?
Yeah.
Some better than others.
Yeah, yeah.
That's good. Right, and then you'll also see that on the right-hand side, there's Gallagher's CCTV mentioned. So sometimes that's what you see on the screen, and sometimes there's Snapchat footage
Yeah.
that will all be combined within the real time.
Yeah.
Right. So again, if you want to refer to the spreadsheet at any time or just check anything, please feel free to do that as well.
Okay, thank
So
you.
everything you have in front of you, you can use as you wish.
Okay.
And if you need time to look at footage again, or you want to check something, or you want me to bring something up on the screen, just you tell me.
Okay, thank you.
Thank you. Great. Now, if I can paraphrase, when your senior counsel, Miss McCall, spoke at the beginning of the inquiry, giving an opening statement, she said that you want the chair to get to the truth of what happened, and that's why you're here today, to help assist the chair in doing that.
Yes, that's correct.
And that remains the position today.
Yes, it does. Yes.
Thank you very much. Now, to be clear, you weren't at the scene when the airwaves transmission said officer injured.
That's correct.
That's right, isn't it? And you arrived later with Constable James McDonough.
Yes.
Right. So what I'd like to do is just play about 1 minute of the footage, and I'm going to show you some vehicles arriving, and I want to see if you can recognise the vehicle you arrived in.
Sure.
So can we look at the evidence video timeline, please? And if we play the footage really just shortly prior to your arrival, so from 7:21, and we play that just a full minute from 7:21. And feel free to look at the spreadsheet. So you can see that 7:21 is on page 4 of the spreadsheet.
Yeah.
And you'll see the timings going down the left-hand side. But I think first of all, if you don't mind, first viewing, if you could have a look at the CCTV we see on the screen.
Sure, that's fine.
And then I can go back over that if you want me to show it again.
Okay, thank you.
That's great. So 7:21, and if we can, we're very close to that, so we'll just play a sort of minute up till 7:22. Thank you very much.
Monday 4, control keep off us. Someone activated the emergency button. Officer John, PC sir, Rail. Control acknowledge, officer injured. What's the locket? We've just got blue lights stopped, chasing the Gallagher to approaches. Thank you. Control Bravo. however, one officer's been punched in the back of the head, no obvious serious injury, male secure on the ground. 30 seconds out, 4-1.
It's my fault. If you're alive, you didn't give me an update, please.
Right, that's lovely. Thank you very much, Miss Smith. Could we go back to 7:21:46, please? Were you able to see the CCTV there?
Yes.
So, when we started playing that footage, there were 2 police cars already on Hayfield Road. And we've heard that the first one was a transit van driven by PC Walker with PC Payton in the front passenger seat.
Yes.
And then the second one contained PC Tomlinson and PC Short. And then you may have seen blue flashing lights coming from the other end of Hayfield Road towards the roundabout that we're looking at. And we've heard that that was driven by PC Smith and the front passenger was PC Good. And then at 7:21:46, and we'll just play for a couple of seconds and pause if you don't mind. That's, if we could pause there, thank you. Now we see this police vehicle driving from Henry Road to the roundabout with Hayfield Road, and then it's about to turn right. Whose car's that?
So that was the car that I was driving.
Right. So you were driving that, and was that a Vauxhall Estate Astra?
I think that's how I've described it as, yeah. I don't know if it's an Astra, but it was definitely like a Vauxhall kind of estate type car.
Right. I'm not going to debate with you that. So that's we think it's an Astra, and that's the car that you're actually driving.
Yes.
And is PC McDonough in the front passenger seat with you?
Yes.
So that's you, the 4th car to arrive at the scene.
Yes.
Thank you
Yes.
very much. And you'll see, if we look briefly at the reconstruction tile, which is at the top of the screen in the middle, you'll see that this is a bird's eye view of Hayfield Road and the roundabout. It's a 3D reconstruction.
Yeah.
Do you see at the roundabout now there's a white vehicle shown there?
Yes.
And that's to symbolise or be indicative of the car that's on the roundabout now, your car. So can we just play for a couple of seconds and you'll see it going round there. And we'll see it stop in Hayfield Road. Now, if we can just pause it there. And you'll see it on the CCTV, it's actually blocked behind that white van that's actually just about to move. And we've heard evidence from the driver of that vehicle. Do you see on the reconstruction tile, is that a reasonable indication of where you stopped in Hayfield Road?
Yeah, I'd be quite happy with that. I mean, I don't know if it's exact, but yeah, certainly if you're looking at it, it would certainly match up with the CCTV, and from my recollection of where the car was parked, that would seem
great.
accurate to me. So
That's great, because these are the reconstructions are only indicative.
yes.
They're not exact, precise measurements. But if you're happy with that, that's very helpful. So, thank you. Can I now move on to your inquiry statement, please? And we'll have a look at paragraph 1 first of all. And you'll see that on the screen. And you say that you refer to your PERC statement that we looked at a moment ago, and you say, I saw PC Nicole Short. It was clear from her demeanour that she was going to something. I asked her what she was going to. She told me that she was going to a call about a man kicking about Henry Road with a knife. My radio was not on, so I'd not heard the call. So this is, as I understand it, this is how you became involved with this incident at Hayfield Road.
Yes, that's correct.
So your radio wasn't on at that time, but you'd spoken to PC Short, and that's how you became aware of the incident ongoing.
Yes, that's correct.
Thank you. And then you say that I said to her that me and PC McDonough would attend the call as well,
as that is what tends to happen when there's been a call regarding someone with a knife. The whole shift attends. Was that the norm in 2015?
Certainly for that, yes, it is. So this incident happened on a Sunday morning. Also, it's not mentioned there, but the car that we were on was classed as the diary car, which is used for appointments. Now, I can tell you the kind of times now, but what used to happen was the first diary appointment call, these were done for non-emergency calls. The first time these used to start were about 8 o'clock in the morning. So certainly for this type of thing, yes, answer your question, everyone would probably go if they've not got other commitments. And certainly if there was other commitments, then the diary car would have definitely went anyway, because their first commitment isn't till 8 o'clock, half 8.
You don't want to turn up at people's houses before 8 o'clock on a Sunday morning.
No, definitely not.
You wouldn't be very popular.
No, definitely not.
So we've heard that the transit van was called the 19, and we've heard that the smaller van that was second on on Hayfield Road was called the fish van, and your vehicle was called the diary car.
Yeah.
Right.
Yeah.
Okay.
Yeah. Not necessarily that exact vehicle, but yeah. So our call sign was the diary car call sign. So in essence, that then becomes the diary car, if you understand what I mean.
So it was more the status.
Yes.
You were taking the role of that.
Yes.
Okay. Thank you. Can I ask you about who you expected to turn up? You've said the whole shift attends. Who would you have expected to be attending the call at Hayfield Road?
Probably everyone who was on duty on our team that day.
Okay. Who was that?
So there was PC Walker, there was PC Payton, there was PC Short, there was PC Tomlinson, PC Smith, PC Good, myself and PC McDonough.
And you said that was the norm for the shift to attend?
Yes. For a knife incident,
Right.
especially at that time in the morning, if there wasn't any other commitments.
Okay. And we've heard that that was called a response team.
Yes.
Is that correct? Can I ask you about previous experience of knife incidents that you had? So this wasn't the first time that you'd attended incidents where there was an allegation that someone had a knife, was it?
No.
So could you tell us a little bit about the number of incidents that you'd previously attended prior to May 2015?
It would be hard to put a number on it. There would definitely have been knife incidents, knife calls. What I would say is, with regard to this situation, this knife call, if you like, that's rare, that type of call. I have never been to a call like that before.
Sorry, I interrupted.
No, sorry.
Carry on. I was just going to say, why do you say it's rare? You'd never attended one like that.
Well, prior to that, and actually after, I don't think I've ever been to a knife call like that where there's been calls that came in. Again, I'm not aware of the calls at the time, we've established that, but when you look at everything, there's calls from members of the public saying that there is a male, he's in possession of a knife, he's in and goes from one street to another street. I've not had any dealings with anything like that.
Right. So what was it about this particular incident that made it rare? Was there anything in particular that made it unusual for you?
Well, again, probably just the number of calls that there's been, the fact that when I went there as well, emergency button activations, things like that. So yeah, that was rare. Also, probably who the emergency button activation was from was very surprising as well.
And were you aware that there'd been emergency buttons activated?
Yes, I was certainly aware of the first one, and I believe I was aware of the second one, although there was some confusion with the second one as to who had pressed it. It was between two officers, and I couldn't make out which officer it was, the second activation. I know now for this, but I was confused what officer it was for the second emergency activation.
Right. And we've heard now that the first one was PC Payton.
Yes.
And the second was PC Tomlinson.
I believe so, fair.
What was it that made you think that was unusual? Well, you mentioned the fact it was the person who pressed the button.
Mm-hmm. So, emergency buttons don't tend to be pressed a lot. I'm not aware of many incidents where the emergency button has been pressed. So, I had worked on that team. I pretty much knew everyone on my team. I knew Alan Payton. So, PC Payton was definitely over 6 foot. I know what we're, he's apparently 6'4" now. I would probably put him about that height anyway. Could certainly look after himself. I think if there was any kind of altercation, you know, there's PC Walker, there's PC Alan Payton. They're two of your biggest guys on your shift, effectively. You know, when one of them's pushing an emergency button, that could cause a bit of kind of panic. What's going on? You know, I'm not there.
When you say it can cause panic, how did it make you feel knowing that PC Payton had pressed his emergency button?
Well, again, I didn't really know. Obviously, I knew for Nicole Short that she was going to a knife call. I guess it just made me wonder what was going on there. Again, I'm not at the incident yet, so I can't see what's going on. But I found, oh, there must be something serious. That's the way I kind of thought it. There must be something serious, or something's going quite wrong, that this individual's pushed his emergency button.
Right. And when you say it can cause panic, did it cause panic in you?
No, it didn't cause panic in me, because at the end of the day, I was just driving to get there. So it didn't cause, not panic per se, but that alerted me more that PC Payton had pushed his emergency button, as it would to just maybe say, take for example, PC Tomlinson pushing his button.
Right. Okay. And you've said you knew PC Payton, you knew he was an experienced officer,
yes,
and he could handle himself, I think
yes,
you said. How long had you been on that team by that time, May 2015?
A year, maybe?
Okay.
I'd obviously been on other response teams before.
Right.
Yeah, a year.
And during that year, for example, how many times had you attended knife incidents or calls which made an allegation someone had a knife?
I couldn't put a number on it, to be honest. I know at one point I said in my statement about limited experience with knives. What I would say is that there is a lot of knife calls. There's calls with self-harm, stuff like that. When I have said that about limited experience with knife calls, I mean at this kind of incident, on this kind of scale.
Right.
But yeah, there's a lot of knife calls or knife allegation calls. But I couldn't say how many.
We've heard other evidence that they're quite frequent or they're regular. Was that your experience in Kirkcaldy?
Yeah, they can be quite regular.
Mm-hmm. And can you tell me, did any of those previous knife calls or knife incidents involve any black men?
No.
Okay. And did any of them involve people, you've mentioned self-harm, but did any of those involve people who were at risk of self-harm or self-harming because of drink or drugs?
I think I can recall I'm sure there was one incident.
Tell us about that.
Well, I can't be sure of all the details, but I don't know if it was through drink or drugs. I couldn't say. But I've definitely been to self-harm calls that involved a knife before.
Right.
Definitely.
And you've been involved in call-outs where people were on drink or drugs?
Yes, definitely. I remember one incident. I think that was before 2015, actually, and it wasn't a knife, but you can. The female had a pair of scissors, which could still be classed as a knife. It's a sharp implement. You can cause injury. And I recall it was a self-harm thing. I'm sure she was on a bridge, and it was between jumping or self-harming.
And that was something that you responded to?
I had responded to that, so I think other officers were in attendance as well. I built a rapport with the female, and ultimately ended up with her not jumping, not self-harming, and I'm sure I ended up in the ambulance going with her, and I think we went to the hospital, or the Whitemansbury Hospital,
All right.
for a mental health assessment.
We've heard that that's a psychiatric hospital
Yes,
near
yes.
Hayfield Road.
Yes.
Yeah. And so in building the rapport with that female, how did you manage to do that?
I mean, it was just for communication, maybe trying to relate to her experience, what she's going through, how she's feeling, see if you can relate that to an experience, a past experience you've possibly had.
And we've heard that communication can sometimes be called tactical communication.
Well, yeah, it can. For me, I wouldn't have classed it as that, because for me, I just felt like I was communicating with the female, and just like I was having a conversation with her.
Right.
So,
And that's how you were building rapport with her.
yes,
And the aim of that is to see what's wrong,
Yes.
and to see if you can talk her down off the bridge, or get her to put down the sharp implement.
yeah. Well, I mean, definitely that's our goal, so that she, yes, she's not going to jump or put down the sharp implement, and then after that we can obviously discuss other things and help that we can maybe get her, stuff like that.
So you were aware at that stage that it was a medical emergency that needed your assistance?
I certainly, from her actions, yes.
And as you were building that rapport, was she communicating or conversing with you as part of that process?
She was conversing for the start, but very limited.
When you say limited?
So limited, like, so if I'm having a conversation with you just now, it's like you saying hardly anything to me. Yeah.
Right.
Okay. And it was minimal.
So how did you deal with that minimal response from the female?
Just kind of being persuasive. Just sometimes it's about going over the same things again. Just keep communicating.
Mm-hmm. Keep speaking to
Yeah.
her? And that seems to have worked in this occasion?
Well, I think so. I mean, I'm not a health professional and don't know how these things work, but I felt that just speaking to her, maybe the first time she might not listen, maybe the second time she might not listen. If I keep on going, my goal is to ultimately try to get her off the bridge, drop the scissors, and if I could do that, I've kind of won the battle there. And then we can speak about other things, try to get the help, go to the hospital, talk about things, whatever.
So you're continuing, you're trying to keep that communication line open.
Yes.
And you're obviously using a nice conversational tone with me today.
Mm-hmm.
Is that the type of conversational tone that you were using with this female?
In that instance, yes.
Yeah. So can you describe the tone that you're using when you're speaking to someone?
Probably a bit more sympathetic than how I've been speaking to you, but
I don't take
but,
offence.
Well, not I don't mean that. I don't mean that. This is me talking normal to you, but probably I can't give you an example. It's similar. It's maybe a little bit softer, but yeah.
But it worked in this incident anyway.
Yes, and at no point would it ever have been aggressive in that situation, because she's on the bridge, she's got the scissors. That just wouldn't be the case.
So not aggressive, not shouting.
Yes.
Not shouting commands or anything along those lines.
No.
Okay. Now, the previous knife incidents that you dealt with, you've given us an example there, but did any of those involve the use of sprays, either CS or PAVA, prior to May 2015?
No.
What about any other equipment like batons? Did you ever resort to using your baton?
Have I ever?
Yes, have you ever?
Yes.
Prior to May 2015?
I don't know. Maybe not.
Maybe. Do you remember?
It's around that kind of time.
Do you remember any incident where you used your baton around that time?
Yes.
Tell me about that.
So it wasn't a knife incident, no?
Oh, right. It wasn't a knife incident. Thinking about knife incidents.
Right, sorry, that's my
No,
fault.
no, it'll be my fault, please. So thinking about knife incidents roundabout or prior to May 2015, had you ever resorted to using your baton
No.
in that type of
No.
situation? No. What about other officers that you were with?
No.
No. And sprays? I mentioned sprays a moment ago, didn't I? You said no to that. So, what had you ever resorted to restraint in relation to one of those knife incidents prior to May 2015?
When you mean restraint, like even if I put on handcuffs, for example.
Right.
So that female, the example I gave with the bridge, with the scissors, I think she was put in handcuffs for just her own safety at the end, and she was quite fine with that. So
I'm thinking more along the lines of wrestling someone to the
Right,
ground
okay.
or being on top of them, trying to put hand where someone's resisting.
sure, I can't recall.
Okay. You don't recall that being done?
No.
Right, okay. Can I move on and ask you about your journey to Hayfield Road?
Yes.
So I think in your statement you mentioned that as you were leaving Kirkcaldy Police Office, were PC Smith and PC Good also leaving at that time in their car?
Yes, or they were out in the backyard at the same time as us.
Right. And you've told us already you were aware of emergency buttons having been pressed. And then at paragraph 3 of your inquiry statement, and we could have that on the screen, you said you didn't carry out a risk assessment en route as you were waiting until you arrived to see what the situation was then. And I'm quite interested in that. You've told us that you were driving.
Yep.
And you say there that you didn't do a risk assessment en route. Can you give us a little bit more explanation of why you weren't doing a risk assessment en route?
I didn't do a risk assessment because I didn't know what to expect. I was going to carry out a risk assessment when I was there.
Right.
How I've took this is I've not yet heard the emergency button either, so I am en route going. I think we were going out. I've obviously seen PC short. She's told me where she's going. I says me and James McDonough are going to attend. We then go out. We then start heading in a direction. At some point, now I haven't heard this, but obviously I've seen for the footage. APS Maxwell says, I want all units to attend. Okay, I've not made the risk assessment.
Right. Can I ask you said you were on this response team for about a year.
Yes.
Before May 2015. So did you know Hayfield Road? Did you know the area it was in?
Yes.
Yeah. And did that make any difference to you knowing Hayfield Road?
In regard to a risk assessment?
Yeah, just in regard to your confidence about attending that area?
No, I certainly had confidence in the area. It didn't make a difference to my risk assessment. I mean, I am aware of the area. I'm aware that there's obviously Whiteman's Hospital, there's a Victoria Hospital. I don't know if it's a church now, but there certainly was a church there at one point. There's a cemetery, and there's residential houses.
We've heard there's houses and things, right. And then you mention Police Sergeant Maxwell. Who was in charge of this incident and the response to this incident?
So at the time of response, it would have been APS.
It was
Sergeant Maxwell.
Sergeant Maxwell. Can I ask you to look at your PERC statement? So this is 258. And this is your statement of the 4th of June. Page 4, paragraph 2, please. And you'll see there, it's on the screen as well. It says the transmissions were very muffled, but I heard officer down. I think it was PC Alan Payton. I could see on my screen that it was his number 694 that came up on the screen of my airwave radio. There was muffled breathing like someone was out of breath. I got the impression that there was a struggle going on due to this, but the only words I heard distinctively were officer down. And I think you said earlier there was some confusion, but you thought that was PC Payton that had made that transmission. Is that right?
The first transmission.
Yeah.
The first emergency
The
button, yeah,
officer down transmission. It says, I got the impression there was a struggle going on due to this, but the only words I heard distinctively were officer down. And you thought that was PC Payton.
Yes.
Thank you. Would you like to listen to that transmission again before you confirm the position?
Yeah.
Yeah. Well, let's play the evidence video timeline. You'll see actually, Constable, that it's on spreadsheet page 4. So as you're listening to this, it's 7:21:02. You'll be able to look at the text. So it's on page 4 and it's 7:21:02. So it's about a third of the way down. Have you found that it says officers injured?
Yes.
Yeah, that one. So I'm going to just play that for you. It'll just take a few seconds and then I'll let you see whether you still think it was PC Payton.
Thank you.
Thank you very much.
Officers injured. PC sir. Bravo.
Thank you. And is that, you still recognise that as PC Payton's voice?
Yeah.
Thank you. And is that what you're describing on page 4 of your PERC statement? The one?
Sorry, the picture.
No,
Yeah,
sorry,
yeah.
there's a lot of paperwork to get to grips with.
Yes, that's
Thank
what's
you.
right.
Thank you. I'd like to ask you, as I have with all the other officers, about your state of mind as you were heading to Hayfield Road. So what was your sort of state of mind? And I mean by that, how were you feeling? What was going through your head?
Well, to start with, I wasn't really feeling in, and I was concentrating, just driving the police car. To start with, I actually thought it might have been a hoax call.
Right. And what made you change your mind?
When the emergency button was activated.
So that was the key moment for you,
Yes.
that you realised it wasn't a hoax call anymore. And can we look at your inquiry statement, just so you have that in front of you? And it's paragraph 12. And this is where you've mentioned this already actually, but this is where you say you have limited experience, but I would have attended incidents involving knives. Do you see that one?
Yeah.
And then you say, my experience of such incidents remains limited. Taser officers are now typically sent to knife incidents, and I have not been a response officer for around a year, so I've not been exposed to a knife incident during that time. Can I just check, we've heard that it was in 2015, it was firearms officers that had the tasers, but normal police officers responding didn't have them. Is that your recollection?
Yes.
Yeah. So that wasn't something that you had available to you as a constable in May 2015?
No.
Right, thank you. But what you did have was that you were fully trained and your training was up to date in May 2015. And you had some equipment with you. Can I just confirm that you had did you have PAVA spray with you or CS spray?
No, I think I would have had CS spray.
You were
'Cause I
still
think-
CS?
Yeah, I couldn't be certain. I think PAVA got rolled out a bit later, but I think some officers had it, but it was only a few.
We've heard
Yeah.
that some people had replaced it and got the PAVA
Yeah.
spray. Right. And then you had handcuffs with you
Yeah,
and a baton.
yeah,
And were you wearing a stab vest?
yes,
And you had a radio.
yes.
Lovely. And can you tell me what height you are, PC Gibson?
5'11".
Right, thank you. There's some references in the papers to 5'10", there's some references to 5'11". I just wanted to check.
The last time I checked, it was 5'11".
All right, that's good. And as I understand it, in May 2015, you were 12 stone. And is that the same as your weight today? I don't want to embarrass you in any way.
No.
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 And now, are you one of the few that's gone down in weight, or are
No,
you up?
No,
You're
I
up.
went up slightly.
All right. So, can I ask you, have you gone up much or just a little?
No, just a little. So I'm probably just sort of 13 and a half.
Right. So roughly about 5'11" and about 13.
Yeah.
13 and a half. Thank you. Did it make, you've talked about how hearing the emergency button, particularly from PC Peyton, made a difference to you. Did it make a difference to you knowing en route to Hayfield Road that there were other experienced officers going to be there as well?
No, not really.
No? And did it make a difference to you travelling to Hayfield Road that PC McDonough was with you?
No.
No. And we've heard, we may hear that PC McDonough is 5'6.5" tall, and in May 2015 was about 10 stone 2. That seem about right then?
His height would have been that, yeah. I mean, I don't know his weight, but he was definitely smaller than me.
He's smaller than you and
yeah,
slimmer than you at the time. And he was at the time about 21 and had 6 months police service, I think.
Yeah, but I remember the 6 months, yeah. So.
Okay, lovely. Now, in paragraph 6 of your inquiry statement, you say that, if I can find it, oh no, yes it is. Sorry, it's towards the bottom of that page. So you're asked, what account, if any, did you have to the threat level? And you say you took no account of the threat level, this was just a knife call. And I'm interested in that. Now, other officers have said they did take account of the threat level. I'm interested in the fact you say you took no account of that. Why was that?
At first, I wasn't sure if I understood the question. However, I was aware of the threat level.
Right.
However, the threat level made no difference to this call for me, if that makes sense. Yeah.
Mm. And why do you say it made no difference to you?
Because I just thought it was a knife call.
Right.
I didn't at any point think it was terror related.
Right. But the threat level, do you remember what the threat level was
Severe.
at the time? Severe. And you say that you didn't think it was terror related. So would an officer normally connect the threat level to a terrorist, potential terrorist, or you don't know?
I couldn't say. I certainly didn't connect that.
There was no connection in your mind?
Definitely not.
And so did you make any connection at all with the fact that the man said to have the knife was a black man? Did that have any bearing on the way you were thinking when you approached Hayfield Road?
No, it didn't have, but I don't think I was aware of race before I got there.
All right. So you weren't aware that it was a black man?
No, because I'm sure PC Shorty says she was going to a male kicking about with a knife.
Right. Not that it was a black man. Thank you. So I'd like to go over what was happening. Now, I'm conscious that we've got 2 minutes before the normal lunch hour. I'm going to move on at this stage and ask you to look at some 3D images.
Sure.
So
yeah.
I'll just let you see those before we move on, but there's still images 2, and I think if we look, say, at image 4, now you might have had the chance to see some of these if you've looked at other evidence being given. And let's just look at image 4 first of all. And you'll see that that's an image of Hayfield Road. And on the left-hand side of that image is the roundabout with Henry Road.
Yeah.
And we see 3 vehicles there, white police vehicles. The transit van at the bus stop, you see that one?
Yeah.
The fish van on the same side of the road behind the bus stop, slightly towards the centre of the screen. We've got the van that's on the far right, which we've heard was driven by PC Smith with PC Good in it. And then the vehicle on the far left, is that the diary car?
Yeah, that's.
And are you comfortable with that position there?
Yeah.
Yeah, that's lovely. Thank you very much. Now, what I'm going to do is move on and start asking you to sort of position people in that scene, and you'll know that you can touch the screen and a red circle will come up.
Sure.
Do you want to practice that at the moment? Just could you tell us where you were when you got out the car? of the diary car, please.
So just when I exited the vehicle?
Yeah, it's just when you got out.
Alright, so-
Right.
Well, a bit closer.
Yeah, so we can fine-tune these things in
Right.
due course if we need to.
Yeah.
But you're essentially just getting out of the driver's side, and you were just on that side of the diary car in Hayfield Road.
That's correct.
Lovely, thank you very much. Would that
That'd be a suitable time to stop for lunch. I was sitting in at 2 o'clock.
Thank you very much.